This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 629, recorded on June 19th, 2020. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York State, Daniel Griffin.
Hello, everyone.
The week seems to go by quickly, Daniel.
Does it? I think it does.
You don't, huh? Also joining us from New York State, Chuck Knersch.
Hi, Vincent. Hi, Daniel.
So, Daniel, are you still well? You still working hard, or you take some time off?
I am still well. I think as people listen to this, I'll be just about to head into another 12-day stretch of lots of work and no time off. But no, I'm staying healthy. I'm doing well. I realized I was watching. I don't know if you guys got a chance to watch the PBS Frontline special. But I noticed, boy, I looked like I need a little bit more sun and more sleep. So, Chuck, I'm going to take your advice to heart.
That was
2 hours a night's not enough, Daniel. That's what I was scolding you for last time.
Yeah, I'm getting bags under my eyes. It's terrible. So,
right.
Yeah, so I'm going to start balancing things better just in case they do another Frontline special and I have to appear. I don't want to look so tired and, so.
It looks good. It looks like you're working hard, right?
Yeah. Well, someone made a comment because I said that, and they said, a lot of the other people are not seeing patients, so many hours. So yeah, I actually I asked my one of my staff to go through like how many encounters have I had since the beginning of the pandemic with COVID patients, and it was. You want to guess?
Let's see. I'm thinking how many you had in a hospital at any given time. So I don't know. I'm going to throw out 1,000.
So it was 1,735 COVID encounters.
Wow.
And so some of these are, the same patient that I saw repeatedly, like the Irish patient who I saw about 50 times. But yeah, it's sort of just shocked at the volume, sort of averaging seeing, more than 20 patients, with COVID or a day.
But not every patient you saw so many times, right? I would guess.
Yeah, a lot of patients, and I think we talked about this, I would see once, I would kind of go through the whole thing, and then, I would go through with the hospitalist and, say, hey, if you got a question for me, just let me know. I'm not going to, necessarily go physically see the patient again. But, now I know sort of the whole story. So, you can call me at 1 a.m. and I'll give you my take on what we need to do next.
Well, I think that's why, specialty training, specialty expertise is something that leads to better outcomes for patients. And that amount of volume led you to sort of decipher a lot of different interventions, steroids, IL-6, anticoagulation, as we'll probably get to a little bit later in this talk.
Yeah, no, I think that was really helpful. You do need to see a lot of patients to start picking up on patterns, getting insights, hopefully coming up with those observations that then can form the basis for clinical trials. I was reading some recommendations recently, and they actually one of their they had qualifications for people writing the guidelines, and it was they had to have actively seen the patients that the guidelines were addressing. And it's tough when I see sort of these talking heads, and and the majority of them have seen no COVID patients, and I always thought that was really hard for people to be making recommendations about the care of patients that they had never actually seen, managed. So
Daniel, many parts of the U.S. cases are increasing as people get back to their lives, and I'm wondering what you're seeing here in the New York area.
Yeah, I always try to prepare like what are the things that we'll talk about each time, and this is a fine place to start. And what I like to tell people when they ask are two things. One is I say we closed the front door but left the back door open. Right? Because we remember early on it was, oh my gosh, we can't have flights from China. Then it was, oh, we can't have flights from Europe. And then, people started asking me, do you think they'll shut down travel in the US? And I was like, they probably should, but they won't. And so what happened, right, is a lot of people, it was actually an interesting article where a lot of people actually moved out of New York City and haven't come back. I think it's like 7 or 8%, maybe even more, just left the city, and they moved to Miami or somewhere else, some out to California. And so as things got under control in New York, and they really have gotten under control in New York, things have gotten much, much better here. If you look at the curves, the number of new cases is really low. The number of deaths is below 100. That's fantastic. But for instance, a couple of the cases that I saw this week, one was a gentleman who winters with his wife in Florida. And, now it's starting to get too hot in Florida. So he and his wife flew back with a stopover in Boston. And then a couple days later, ended up admitted to the hospital with COVID. He's on high flow oxygen, and he already started on steroids. We'll talk about that. We're considering giving him tocilizumab at this point as well. Right, so people get on an airplane, and here's a state where the numbers of cases are rising, and a few hours later, they can be back here in New York. The other was a young man went back to, this is like a euphemism, I think, go back to clean out his college dorm room, which, right? So of course, he went there, he, wore masks, gloves, went only into his room, packed up all his stuff, and then immediately came back unscathed to the family shared house in the eastern end of Long Island. I'm not sure how accurate that description is. What I've seen basically is people go back to colleges and their buddies are there, and they get together. The social distancing is put on hold for a period of time, but this was another case of this individual. The week before the family was going to do this house share out in the eastern end of Long Island, he had gone back to college and cleaned out his dorm room, and now he ended up getting sick. And by the end of the week, mom, dad, aunt, uncle, the whole sort of family gathering is now COVID-19 infected. So, so that back door is wide open, and people can jump on a plane from any one of those states and come right back here to New York. There's it's really sort of parsing words or playing around with the language, because people always ask me, they say, will there be a second wave? And as people have probably heard, whoa, this first wave hasn't really gone away. So as the numbers go up, it's not a second wave, it's just a second peak of this wave. And I think that's semantics at that point. We got up to almost 40,000 new cases per day when we peaked in, it was early on meaning just a couple months back. We're now seeing about 26,000 as sort of a weekly peak day. We went down. The deaths have actually gone down quite a bit more, right? At one point we were seeing, between 2,500 and 3,000 deaths per day. That is now sort of settled down to less than 1,000 deaths per day. So I think we've come down low enough that as things rise, I'll call it a second wave. But I know a lot of people are going to say, well, no, there isn't a second wave because they said there wasn't. And, it's, I remember we used to climb out in Colorado, and we would define how many peaks were above 14,000. And for two peaks to be truly separate peaks and not just part of the same mountain, you had to have a dip, a saddle that went down a certain point. I think we've, at least in New York, we have a saddle. We've gotten it down. So as the numbers rise, particularly, I think we're going to do okay in New York for a little while here. It seems like it, but we're going to have the snowbirds coming back from high risk states, Arizona, Florida, California. So we're going to see cases. Well, as mentioned, I'm already seeing cases due to that. But the rest of the country, the number of cases, dropped from a high of in the upper 30s to a low in the mid 20s. That's not a huge drop. We're still trucking along.
Well, Tony Fauci said we're still in the first wave.
Yeah, I mean, it's semantics.
Yes.
It hasn't gone away. It's starting to get worse again in certain places.
Yeah.
So, yeah. What were the other things we should talk about? So, preparations for vaccinations for the fall. We're getting ready because that's a big issue that we're worried about. And this is still on the same concept of we expect there to be an increase in the fall, and we're hoping that we can get more uptake on the flu vaccines this fall. And it's almost a triage or a Bayesian analysis. If you think about it, if a person calls and it's say end of October, November, I got a fever, I got headache, trouble breathing, I don't feel well. If they've had their flu shot, then it's higher likelihood that we're dealing with COVID. If they didn't get their flu shot, then it could be the flu, could be COVID. Makes it a little bit more of a challenge. I mean, we know the flu vaccines are never 100%, but we're going to need everything we can. So our chief of the Division of Pediatrics, Jay Berger, has been working on this, and Dr. Lawrence Shulman, the head of our ProHealth COVID team, has been really sort of letting people know, start prepping. Hopefully, we're going to do more vaccinations this fall, and that's going to help us. So, people who maybe didn't get flu vaccines in the past, maybe this is the first time. That would be great. We're going to get to steroids, but I'll just talk about telemedicine because I know we have a lot of doctors listening and sort of wonder, what do you do with telemedicine? And I'll say telemedicine is here to stay. We just need to sustain this model and understand how it complements our other abilities to deliver care. It can't replace all traditional in-person visits. I still see a percent of patients in person, even quote unquote outpatients. And the Centers for Medicare and Medicaid Services, so CMS, they've actually been very supportive of telemedicine and with reimbursement and other sort of flexibility. And they've extended that support out till September. So we expect a hybrid model in the future. So this pandemic is going to forever, I think, leave its mark, sort of an innovation on the extension of telemedicine. And, maybe this was good timing because people are a little bit more flexible and forgiving with telemedicine. Because it's a necessity at this point. But once you've actually had one telemedicine visit with a patient, I find that the repeat visits are so much easier. Their computers set up, the microphones turned on. So that's been helpful. The next, and this is why I was so excited to have Chuck on here, is I was hoping we would talk about steroids.
So the recovery study.
Yes.
So you had predicted this, and I think it was about 2 months ago, you were talking about actually a dose of steroids or a trial of steroids before you would go to an IL-6 inhibitor, given the long half-life, given the severe immunosuppression with IL-6. Turns out you were right, Daniel. And that's the expert opinion at the bedside, I think. The recovery study is actually a very innovative design. It's a multi-arm adaptive study where you can add arms to the study in mid-flight. Each arm controls for itself, including having a standard of care arm. And indeed, in hospitalized patients, it looks like giving 6 milligrams of dexamethasone actually reduced mortality by 35%, which is a whoppingly big number in these types of trials.
It is. It's dramatic. And I thought this was maybe a good time to walk people through what was the whole steroid story? What happened? Because people probably remember, I remember this was even before we talked about masks. People were saying, "Oh, don't give steroids to these patients." And so I thought I would maybe walk our listeners through what was the story? What happened and who said what and why was this so controversial for so long? And it's really interesting because February 15th, there was an opinion piece that was published in The Lancet, right? And that's okay. I know it's The Lancet. It's had some issues. But it was an opinion piece out of a group of writers from Edinburgh. So this is Edinburgh, Scotland. These are folks that have, they have not seen any patients with this disease. And basically they just said, you know what, we reviewed the literature, we looked at SARS, we looked at, using steroids and other respiratory illnesses. We just think it's a bad idea. And there's, no clinical data exists to indicate, that you should be using corticosteroids in this disease. So people very quickly said, and the WHO actually got on board with this and said, no steroids. We recommend no steroids. But about 2 weeks later, there was actually a correspondence response back to the Lancet, and this is from physicians in Wuhan. And they said, we of course we oppose the liberal use of corticosteroids, but we do recommend short courses of corticosteroids at low dose, used prudently and only in the more severe cases. And we do believe that this is something that should be studied. So it was sort of interesting that first correspondence to Lancet, there was no data. There was all this sort of discussion about, well, they said this because if you give it in the first week, you're going to double mortality. And it really wasn't a lot of data to support that. There was a lot of thinking. And so then a couple actual studies popped up on the preprint servers because, the mandate was you may not use steroids in these patients. It's contraindicated. We all read the opinion piece in the Lancet. And there was an early low-dose short-term application of corticosteroid treatment in patients with severe COVID-19 pneumonia, a single-center experience from Wuhan, China. And this actually showed that, hey, there may actually be some benefit to using steroids. You may get a faster improvement. The people that we gave steroids to, they're only in the hospital for 8 days versus 13 or 14. They're requiring less oxygen. And it was about this point when some of us started to say, we are seeing so much inflammation in these individuals that it makes sense. Another study came out, and I think this is where we really started to see an increased use. This was the early short course corticosteroid in hospitalized patients with COVID-19. And this was actually a COVID-19 management task force based at the Henry Ford. And here they show that you had increased death. What they did is they said, we think this might make a difference, so we're going to do a before and after. So before, they said, this is what's happening right now. Let's introduce this short course steroid protocol. So they're using an intravenous, about 1 milligram per kilogram of solumedrol, and we'll talk about that. And they saw, once they introduced the protocol, that the percentage of people that were dying went down. The percentage of people that were requiring intubation went down. The percent of people that were escalating to require ICU level care went down. And about this point, we started using it quite a bit more broadly. But again, it was sort of going against dogma. Like, people were quite upset and how could you possibly do this? And I think I remembered on one of the TWiV talking about, there was a more senior ID doc who came in and, what was this patient doing on steroids? Don't you know? And it was actually a colleague of mine, an ICU doc. He's like, well, look, there's this data here and we're seeing all this inflammation. And we started noticing, when you're doing something that reduces, the mortality by 30%, which now we're seeing confirmed in the study, that's something you can see in real time. The interesting thing about this study is, I think that when people saw this come out, I read a bunch of reactions to it, and this is why I hope Chuck will be able to sort of help with this whole people, sort of the same. Oh, this is just a press release. We can't do medicine by press release. But I'm actually going to point out that this isn't really medicine by press release. This recovery trial, we have more data and more information on this than you usually get in a publication. We had plenty of time to see about how the recovery trial was set up. We have all the methods, all the statistical analysis. There's an independent data analysis group. So what we're really seeing here is the entire paper was, in a sense, written ahead of time with, here's the results, here's the methods, here's everything you need to know. And then what came out here is the results section, right, of this trial with, 11,500 patients enrolled in 175 NHS hospitals in the UK. And this arm of the study was, 2,000 patients in the treatment trial and the treatment arm, and over 4,000 in the comparator arm, so in the control arm. And statistics that are really impressive. The reduced deaths in the ventilated patients was, a p-value of 0.0003. I mean, this was so dramatic a difference. The number needed to treat, I don't know if people are familiar with that. You for every 8 people you treat, you've saved a person's life. And they followed this data out. This isn't 1 week, this isn't 2 weeks, this is out to 28-day mortality. So people say, oh, these people are going to just go on. They're going to end up, with bacterial infections. They're going to die anyway. All you did was, protect them for a little window. No, this is out past discharge. This is really impressive. And I think, I'll say practice-changing landmark. Really, the first drug shown to improve survival in COVID-19 in a proper randomized controlled trial.
I think just the other thing to comment on, this is the Oxford Clinical Trial Group. These are leaders in the field in innovation and clinical trial design. And this study in itself is innovative, the way they can add arms to the study, and then they have second wave randomization to tocilizumab if you're progressing poorly. I think the studies that were withdrawn are different. They're observational studies. It's big data. Well-trained epidemiologists with a computer that has significant power can get a data set and analyze it. And it's not the same thing. Those types of findings compared to randomization in an excellent clinical trial unit.
And these are all hospitalized patients, is that correct?
Yes.
These are, I think it's important to point out, there really were 3 groups that they looked at. So there was the group of patients that, were mild, didn't require oxygen, so required no respiratory intervention. Those people, there was no benefit. And I think that, that was what we've been sort of talking about. Don't do anything unless you need to. These people had mild disease, no evidence of the significant inflammatory component. But the patients who required oxygen, and the patients who actually required ventilation, both those groups had really significant benefits. So this is not something you give to people the first week. It's not something you give to people who are doing just fine. This is a therapy for people with that inflammatory response to the point where they're actually becoming hypoxic. So their oxygen level is low and they're requiring oxygen, all the way up to patients who are so severe that they're requiring ventilatory support.
So if you did give this early on, it would be detrimental because you'd be suppressing an antiviral response, right?
I still suspect that. I mean, and there's no benefits. So, yeah.
And was there any harm in giving this? Did they report any of that? I didn't see it, but...
Do you want to jump in on that, Chuck? I mean, they and this will be interesting to see kind of the details that go through, but the dramatic reduction in death, but we're not seeing, sort of details of, well, what percent of the people that survived had, required antibiotics for a secondary infection, et cetera.
Yeah, I think the full details of the paper we need to look at. And I think some people have said that, but this is such an important result that I don't think withholding it, and the amount of detail they gave, as you mentioned, Daniel, was good.
Mm-hmm.
So this will be in probably Lancet, within a month.
Yeah. So is this the first outcome of the recovery trial?
It's the second, actually. The other arm of their study that they stopped was this group also looked at hydroxychloroquine. Okay. In hospitalized patients, and they basically said, "Yeah, we're not seeing any benefit. Let's just stop doing that." So yeah, I mean, this group, I think that was the solid data saying we've looked at in hospitalized patients and we don't think it makes a difference versus the retracted paper.
So they have other arms still in progress, basically, like tocilizumab and convalescent plasma, right? We're presumably going to hear about those in the future.
Exactly. I think Chuck mentioned that's sort of the next step, and we'll hear about that in the coming weeks. Okay, the people who got steroids, they're then going to randomize a certain percent of those to go on to get tocilizumab or not, and we'll see. Like, is the steroids giving us this dramatic mortality benefit? Is that enough, or does the tocilizumab add something to people that are progressing? And so we'll learn from the recovery group. We'll also learn from the large French study that's going on. All right, next this was a good week, I have to say. The other is prone positioning. We finally got a paper that actually we've been seeing this, and it's pretty dramatic. I say it's almost like, you turn up the oxygen on the vent, and, oh, wow, now they're not hypoxic. And this was the prone positioning. So JAMA published a paper looking at a number of critically ill patients right here in New York City. And so this was actually done during April. But basically, they were able to show that when you put these people and you prone position them, within an hour, you see a significant improvement in the serum oxygen. So the hypoxemia improves dramatically with this intervention. Actually, this was an intervention just, again, today. That gentleman I described who came back from Florida, initially he got the steroids. He seemed like he was sort of plateauing. And then today his NLR, so his neutrophil lymphocyte ratio, had shot up, starting to have more difficulty breathing. And so I went in and I proned him, sort of took a rolled up bed sheet, put it behind him, kind of get him more comfortable, not quite on his, completely on his belly, but as close as he was willing to get. And, it doesn't have to be completely laying on your belly. If you can lay on your side, somewhat prone, and then maybe switch to the other side after a number of hours, that whole shifting seems to help with the ventilation perfusion mismatch, the shunting that we're seeing in these people. The other is just an update on anticoagulation. We're still waiting for more studies specific to COVID-19, but this is now becoming universally recommended. We've really realized, we've observed that almost half of the patients in the hospital end up with thromboembolic complications, so clotting complications, if we don't do something. So now there's a lot of studies looking at, what's the right dose, what's the right medicine, and then there's even some outpatient ones, because I think, as we've tried to point out, people who never even end up sick enough to get into the hospital during the first week or two, we were seeing those patients have strokes come in during week 3 and 4. So this is just sort of the other, where now that we can do more, it becomes really important to make that diagnosis right up front, so we know who has COVID-19, make sure they're connected to care. I talked to that gentleman who came up from Florida. I asked him, I said, you went to an urgent care, you were diagnosed. What did they tell you to do? He said, they told me to go home and die. And I was like, okay. And so please don't do that. Don't tell people to just go home and die. If we follow these people, we now know, right? If they get to the point where they require oxygen, we have an intervention that can reduce their chance of dying by 30%. The prone positioning helps us. There's a lot of things. Anticoagulation. So yeah, let them know that now we know you have it. Let's keep in touch. Let's make sure we can step in as we need to. And even if they don't end up in the hospital, there are trials ongoing, so we have a better sense of what would be the best anticoagulation to use. And this anticoagulation recommendation, this risk period, is extending out probably 30 to 90 days. So it looks like a pretty long increased risk of clotting issues.
So you said 50% of patients have clotting issues?
Yeah, the data was, different studies, one showing 40%, one showing 60%. So really, really high. And I think I shared some of the frustration I had early on, where we would get a patient through that cytokine storm, they were doing better, we would be starting to plan for discharge, and then they'd have a pulmonary embolism and sudden death on the floor. We just were beside ourselves, because you felt like, oh my gosh, we had just... we thought this was a win. Now we're realizing that there are things we can do to intervene and prevent those horrible outcomes.
Is that the most common complication you're seeing?
It was actually, well, I guess you'd sort of go through the steps. So the first week, right? I don't know if you call it a complication, just felt crummy. The second week was the hypoxemia. Mm-hmm. Requiring oxygen support, usually now, because we've gotten better at not requiring intubation in most cases. But yeah, if we did not do something to address the thromboembolic issues, we were seeing DVTs, we were seeing arterial clots and people losing limbs. And so. And then, we still see that week 4, and sometimes we see people come back with this. They've been discharged, now they come back with bacteremia or some sort of a bacterial infection. And I think I've commented, we see that in people that never even ended up in the hospital, never got steroids, never got anything that touched the immune system. So this seems like there's a post-viral risk of bacterial infections.
And what fraction of patients show that?
Yeah, we don't know yet. Still waiting to see what number. And actually, interesting, we may see part of this data come out of the tocilizumab trial. And I got some of this just sort of feedback about that. So that'll be interesting. It looks like the rate of bacterial superinfections is a little bit higher. Not fatal, right? Most of the people are able to be treated that get these, but it may be a little bit higher. It looks like it's a little bit higher in people that receive immunomodulatory therapy. But that data will give us like what percent are having infections in control group versus treatment group. So that's going to be helpful. But one thing we do know is that the minority of people, when they come in the front door, have bacterial infections. It's 90% of the time, just the COVID virus is enough to cause this.
And the bacteremia is similar to the post-influenza staph and pneumococci?
Yeah, it's really similar. We're seeing staph, we're seeing E. coli.
Seeing E. coli too, okay.
Yeah, the staph I think I was sort of expecting, and I, now every time I see someone with staph bacteremia, I take sort of a very thorough, have you had COVID? And I check serology. And the majority of the time they do, so yeah. But then again, I'm in New York, so let's see, update on the late stage issues. Still a growing number of people that I'm taking care of where they just never get better. Where the fevers continue for weeks and weeks. The interesting thing, and I described this last time and seemed to be consistent, is the biphasic nature, where people tend to get better. Maybe this is that trough and the second biphasic wave of the illness, but then they feel worse again. As mentioned, antibiotics usually don't play a role in this. Just generically give them antibiotics, but some people, as mentioned, might have a bacterial superinfection. So these people need to either be seen or get a chest x-ray or evaluated. But the most common is this chronic sort of chest tightness burning, described as waking up in the morning and your chest just feels like it's burning on fire, trouble breathing, stiff joints, muscle pains, low energy. It's almost like a rheumatological, where there's usually a 30 minutes to 2 hours rough start in the morning. Things get somewhat better during the day, and then evening it starts to get worse again. So growing number of these individuals, and I'm not sure exactly how to deal with that.
Anything else, Daniel?
No, I think well, let me thank everyone for their support of Parasites Without Borders and FIMRIC. That's continues to be really impressive. So thank you for everyone reaching out. I know people who maybe haven't listened before, Parasites Without Borders is supporting the FIMRIC Baduda Clinic in Uganda. So if you go to parasiteswithoutborders.com and contribute, we give twice whatever you give to Parasites Without Borders to support this clinic. And FIMRIC is an organization that is, I guess, the people who run it. There's a number of individuals who run the organization, but the Baduda Clinic is completely run by local Ugandans. So really this is flowing through and supporting the local Ugandans who are really having a tough time, as people might imagine, with this pandemic.
Okay, let me ask you a few listener questions.
Okay.
First one from Kayem. What should a convalescent patient be on the lookout for in terms of a possible second phase late rebound? Any sign of age or pre-existing conditions as rush factors for this? Okay,
yeah. So I am going to say, if you had COVID-19, you do want to be in regular communication with your provider, because there can be complications in the various stages. So I could sort of run through these as, the first week, you feel crummy. The second week, as we see that high risk of pulmonary complications with the cytokine storm, this really kind of tails into second week, into third week, when we start seeing the highest risk of the thromboembolic complications, so the clotting. So you want to be talking to your provider about, do I have coronary artery disease? Am I limited as far as mobility? Because there are certain anticoagulation things you might do. There also is just the generic, try to be as active as possible. Moving is going to decrease your risk of these clotting complications. During that sort of trough period, as mentioned, there is an increased risk of bacterial infection. So if you don't feel well, you want to get evaluated. You don't want to just get antibiotics, because you might have a pneumonia. You might actually have something as serious as bacteria in the blood. And then, unfortunately, during this late phase, I'm not sure we know how to treat it if it's just COVID related. Some patients are finding that Tylenol is very helpful with fevers. We're getting a little bit more relaxed about taking non-steroidal anti-inflammatory medications. And again, at some point we'll talk about that. But again, that was the whole never use aspirin, never use ibuprofen or naproxen was, again, just a letter, sort of an opinion piece from some doctors in France saying like, yeah, we've seen some stuff. We're a little worried about this. But it is pretty dramatic, actually. If you have a patient, they take just one ibuprofen and, oh my gosh, the relief they got. So it's sort of, it can be impressive. But, coordinate with your doctor before taking anything.
All right. Ofer writes, he heard you, Daniel, mention you're starting to see some infections. That's 8 episodes ago. He wants to know if patients coming in with reinfections are also positive for antibodies.
So I don't, I guess I'll clarify. I don't know if we're actually seeing people with COVID reinfections yet. I don't think that's been documented. We certainly saw, and I had a gentleman in the intensive care unit who actually was one of our longest patients who died last week, and actually sort of one of the last of the originals who came in initially, went through the whole process, got better. They did the clap out. He went home. Everyone was excited. About 2 weeks later, he came back with worsening pulmonary symptoms. And he ended up in the intensive care unit, ended up intubated. He was on mechanical ventilation for well over a month until he finally succumbed to this. And, he was one of those gentlemen who was PCR positive for a very long time. By the time he died, he was PCR negative. But yeah, so I don't know if we've actually, I would say there is no clear documented COVID-19 reinfection yet. But we've certainly seen what people have described where people are PCR positive, become negative, have a worsening of symptoms. The PCR turns positive, but we don't know if it's viable virus. We don't even know if it's related to the virus or if this is related to an immune perturbation.
Okay, Margaret wants to know. She read an article in Elemental magazine, which says that COVID-19 is a blood vessel disease, not a lung disease. And she wants to know if virus reproduction in blood vessel cells can explain all of the symptoms like the hypoxia and clots and so forth.
Yeah, so I don't know. I mean, I love this article. This was actually a very good article, I'll say. So people who haven't read it, Dana G. Smith does a great job. But all the things that we were seeing early on led us to sort of think of this as a model, that this was I think we talked about it on TWiV, the idea that it's an endovascular, that's associated with endovascular dysfunction or endothelial dysfunction. And so it's surely acting that way. I do not know if the virus is actively replicating in endothelial cells. So sort of limited as far as information on that. But the activation of the D-dimer, all the thromboembolic complications, I think there's a lot of interesting science that needs to be worked out, relative to all the different stages, right? Because we understand, I think, to some degree, the early viral replication phase. We're getting a better understanding of the cytokine storm phase, but don't really quite understand the mechanics underlying the whole thromboembolic endovascular part of this.
Yeah. I have looked and I cannot find good evidence for viral replication in endothelial cells, as you say. In this article, they link to a Lancet article, which is entitled Endothelial Cell Infection and Endotheliitis in COVID-19. And if you read the paper, it's a 2-patient study. where they have some electron micrographs, what look like virus particles, but there's no identification of them as SARS-CoV-2, and they conclude that it's virus reproducing there, but I'm not convinced. So I would agree with you that we just don't know yet what's going on.
Yeah, it is fascinating, though, I have to say.
Yeah, I bet in the end it will turn out to be immune effects of some sort and not virus reproduction there, but we'll see. None of the animal models, especially the non-human primate models, I haven't seen any endothelial cell reproduction. Two short ones. One is from Beth, who has Graves' disease. She's never had a thrombotic event. She's worried if COVID will trigger APS and she'll get critical. Should be worried, or is this just late night internet-induced medical terror?
Yes, if you go on the internet, you will certainly die of all horrible things, usually by morning. So just to translate a little bit of this. So Graves is actually an autoimmune disease that affects the thyroid. It is an autoimmune disease. The antiphospholipid syndrome, so APS, is you form an antibody that interferes with the clotting system, and it can lead to an increased risk of thromboembolic complications. I'm sort of putting this all together. I think that I could see why your internet search could get you quite concerned. We are seeing only evidence of lupus anticoagulate in a minority of people. And I think I'll clarify, let me explain what this means. So we can actually do assays where we measure, are there antibodies to cardiolipin or phospholipids? And you can measure them. So that's great. You can also do functional assays where you say, okay, I'm picking this stuff up, but is it really functioning as a lupus anticoagulant? And this is really fascinating. There's a silicon base, but I like sort of the traditional. There's a Russell Viper Venom test. And so you take this Viper, a Russell Viper, and you actually get the venom. There are snake farms where they have all these Russell Vipers. And the way that venom works is it causes blood to clot in the presence of lipids. So if you've got this antiphospholipid antibody that is functional, it actually will block the dilute Russell Viper venom from causing it. And then you add a little bit of excess lipids, and boom, it clots right up on you. So early on, I don't know if people knew this, but early on in the epidemic, I bought up all the Russell Vipers in the world. No, I'm joking. We were doing this test early on, and we sort of noticed this issue that people were publishing, like, oh, look, they've got this lupus anticoagulant, but we were doing functional assays, basically saying, yeah, it's not always functional. This may just be part of this diffuse polyclonal B cell activation, and all these immunoglobulins are being produced. And yeah, you can measure them, but they don't necessarily have the antiphospholipid syndrome. There's no actual activity. So I'm going to say that there isn't compelling evidence that you should be more worried than anyone else.
So Beth is a novelist, and you can find, she's got a link to her work there. And I'm just amazed at the different kinds of people we're now attracting with TWiV in the time of a pandemic. All right, one more, Daniel, from David, who heard you on 621 talk about early advice from Chinese doctors to use ventilators. And he says, is it the chicken or the egg? Does being on a ventilator itself cause problems, or would their outcomes be terrible anyway?
Yeah, I'm trying to figure out which is the chicken and which is the egg, but I will say this was something that we watched really closely. We would notice that there would be a person who was becoming hypoxemic, and then we would put them on the ventilator, and they would rapidly get much worse. So the ventilator itself seemed to be triggering an acute worsening. And so we would maybe have them on high flow oxygen, or whatever we were doing to keep them off the ventilator. They were saturating in the high 80s. And so, we had a sort of limited, we're sort of trying to figure out what to do with our ventilators. We weren't using them willy-nilly. So we would say, okay, so this gentleman looks a little bit more stable here. Let's not intubate him now. Let's just watch him. But this gentleman over here, let's intubate him because he meets all the criteria, right? This is early on in the pandemic. And when we would intubate the person, suddenly we would have to turn the oxygen up to 100%. They would become much worse. And this neutrophil lymphocyte ratio, the ferritin, the ESR, the D-dimer, the procalcitonin, all the inflammatory markers would acutely rise right after intubation. So it was actually, it looked like the ventilator itself, that positive pressure was actually driving worse inflammation. So it's a very hard thing, I would say, to study, right? But yeah, we were noticing that just right with the intubation, this would happen. So then what we started doing was delaying intubation. And if you could delay intubation and just use other methods, you seem not to trigger that acute spike in the inflammatory process.
So what is the process where you take the blood out and oxygenate it outside, then return it?
Yeah, so that's ECMO, extracorporeal membrane oxygenation, which I first actually learned about with the hantavirus outbreak. I was in medical school back then, and I actually got to meet like the original doctors and hear the story firsthand. But this was, I think, the first time a lot of people heard about ECMO, and this is where the blood would actually come out, would go through a machine, this extracorporeal outside the body oxygenation device, and it would oxygenate the blood, and then it would go back. And we've used that a little bit in COVID-19.
I'm wondering,
but we're usually using it to people already on ventilators. So it's added to a ventilator, not instead.
Because I wonder if you do that instead of a ventilator, then you have this pressure issue. I just wonder if those patients would do better, or if it's not enough oxygen to help on its own.
Well, we actually talked a little bit about, your field. So the iron lungs with maybe instead of what we're using now is positive pressure ventilation, where you're putting, using the negative pressure where you basically expanded the chest and helped them breathe that way.
Right. Right.
Yeah. So
interesting. All right. Always interesting. All right, Daniel, thank you again for coming with us.
No, a pleasure as always.
We'll see you next week. And Chuck, thank you.
Good talking with you both.
Joining me today from Fort Lee, New Jersey, Dixon Despommier.
Good afternoon, Vincent.
Hello again.
Hello to you too. How's the weather out of your window? I'm looking at you and you're looking at me now.
Big puffy clouds, some blue sky sticking through. I don't know what the temperature is. It's probably, let's see, weather.
It's
28 Celsius.
I would guess 81 degrees.
Which is, it's warm. 28 is getting warm. Is it 82? Is 28 82?
Something like that.
Also joining us from Western Massachusetts, Alan Dove.
Good to be here. I didn't want to chime in before I'd been introduced, but yes, 28 is 82, and it's 28C here. Dew point's 59, so the humidity's not too bad, but it's warm. That's 82, 83 Fahrenheit. Right.
Celsius scale is very compressed.
Yes.
Right, 20 is 68. And 28 is already 82. It's a lot.
Yep. Bigger degrees.
But I like it. I use it, and I know some people don't like it. It's fine. You can use whatever you want. I listen to a podcast.
In the early days of TWiV, we were all Fahrenheit for the weather report.
We were? Is that right?
And said, you should use Celsius. And then we started using it.
Huh. Well, I listened to a podcast this morning where they were talking about this, and one guy said for everything except temperature, he does metric because it makes more sense, right? But temperature, he said Fahrenheit is the way to go because who cares about these arbitrary? I still like the idea that 0 is freezing and 100 is boiling.
That's not arbitrary.
It's not arbitrary.
It's less arbitrary than saying 0 is the temperature of an ice water a bath that's had a maximal concentration of salt put in it. And
one guy said, if you're a scientist and you think you should use Celsius, you actually should use Kelvin. And no.
That is correct. The National Bureau of Standards uses Kelvin.
Well, of course they do. And they use seconds for their time base. So
they do.
So here on TWiV's, Rich uses Fahrenheit, right? So we can use whatever we want. Speaking of using whatever we want, if you like what we do, consider supporting us. Microbe.tv/contribute. We're going to start with some information about 2 outbreaks of Ebola virus disease, which
Ebola, that's a virus that is not a coronavirus. And for a lot of our listeners, it may be news that there are viruses that are not coronaviruses, but this is something we talk about.
In fact,
Right.
I think we will start talking a little bit about other viruses now.
We're going to start sneaking them in there.
We'll sneak them in, but we'll still do SARS-CoV-2 and all that.
Yeah.
But for 2 years, there's been an outbreak of Ebola virus infection in the Democratic Republic of the Congo, the North Kivu and Ituri provinces. 3,460 cases and 2,280 deaths. That's a lot of deaths.
That's for that number of cases. That's a huge number of deaths.
It's over 50%.
Yeah.
But that one appears to be winding down. However, another outbreak began on June 1st in the West, in the Equateur province, and it's a totally independent outbreak. And these Ebola virus outbreaks, every outbreak is a new spillover from some forest reservoir, probably bats, but no one can ever prove it. And sometimes it involves bushmeat hunting, but not always. They spread, and then we get them maybe under control, and then there's a new one. So these two in DRC are two different spillovers from bats. And this time, though, they've been vaccinating people.
Right.
303,000 people have been vaccinated since the start of the outbreak.
It's May 20th.
So August 8th it began. That's with the VSV Ebola vectored vaccine, which was approved globally some time ago.
Okay, so, this ProMed Mail link that you provided, there are apparently a few vaccines.
Yeah, so now there are two new ones.
Right, so there's an Adenovirus 26 based vaccine. And are there two of those?
So there's a second vaccine, but it's a prime boost, where the prime is adeno 26 and the glycoprotein. And then the boost is modified Vaccinia Ankara, which has two spikes that cover two different Ebola viruses. And that is made by Bavarian Nordic. It's actually meant to cover Zaire and Sudan. So the VSV covers Zaire Ebola virus, and this one does both.
Right. And an important thing to know about these vaccines is they've been, I believe they've been tested in humans for safety, and then this deployment, I think, this type of thing is pretty much the phase 3 trial, right? I mean,
that's right.
Because it's not a virus that people are usually getting exposed to, so the only way to test it is to wait for an outbreak.
Exactly.
And unfortunately, Democratic Republic of the Congo has a big enough outbreak where you can do a sizable trial, and hopefully this thing's going to work, or some combination of them will.
Have they tried it in those two provinces?
Well, yeah, they're being used. Well, for the first outbreak, which is on the east,
right?
They've given 300,000 doses out so far, and that seems to be winding down. So maybe that contributed. I guess it did, right?
Okay, all right.
But obviously, so this is a licensed vaccine, so there are no control groups anymore. It's just given to people,
right?
And so I assume not everyone gets it who should because of the politics of that country, right? It's a little messed up.
That's a nice way of putting it, yeah.
And the other vaccine is what's the status? It's a candidate. So this one, if I'm on the Bavarian Nordic site. They say it's a vaccine candidate. So I guess that's still being tested here. But many thousands of doses of that one, and that has to be given in 2 doses: the Ad26 and then the MVA. But they're both vectored vaccines. And by the way, all 3 of these, the VSV, Adeno26, and MVA, they're all being used for SARS-CoV-2 experimental vaccines.
Right. Yeah, these are pretty standard vaccine platforms, which is one reason that it makes sense to do this type of thing, because these are platforms that have been proven, they've been proven safe, they've been proven to work for certain definitions of work and various antigens, and so it makes sense. I really hope that some data are going to be, because this is not the way, as you say, there's no control group. This is not the way you would do a clinical trial. But I hope that we're going to get some data at some point about figuring out how efficacious these are.
It would be nice.
You could start by just asking whether any of the people who have caught it already received the vaccine, right?
Yes, right. So that's the way you would do something like this, is to you distribute the vaccine as you can, and then look at the population of people who show up infected and see what proportion of them were vaccinated. And if you see, a lot of folks showing up who were vaccinated and got the vaccine, then, that would suggest that maybe the vaccine's not working. So I'm just going to adjust my light.
Yeah. It would be nice if we see those data at some point, right?
I'll say.
But
maybe also plotting out the distribution of the acquisition of the cases, and you've got, where they gave the vaccine and where the disease was, and you can just see this abrupt stop to the spread of the infection as it reaches the vaccinated group. That would be another way of telling, but
I mean, I
too good to be true, probably.
Those data must be somewhere, but I just looked at ProMed Mail for this, which is a great source. Not a lot of press coverage of this outbreak. I haven't seen much anywhere. Of course, it's being overshadowed by SARS-CoV-2, but I mean, it's a serious disease. It kills over 50% of the people. And
there was a Lassa outbreak, too, in Nigeria, just about 3 weeks ago.
Yeah, if you look at ProMed Mail, there are lots of outbreaks, actually.
It's amazing. It's just like you throw a handful of darts.
So this stuff hasn't stopped just because of the SARS-CoV-2 pandemic. And by the way, I have now changed back to orange because apparently
you have
my daylight bulb just
blew out.
The ghost.
Really?
So that was a very short lifespan.
Your artificial tan just
it only has so much daylight in it, right?
Yeah, I guess I ran out of day. Well, I thought we were saving the daylight with the time change. Not.
You're right.
But there is a ray of hope.
So next week we'll talk about some other outbreak that's ongoing. This is
maybe eventually we'll talk about some other virology stuff besides just outbreaks.
That'd be nice.
Certainly, plenty of that. This is interesting though because up until a few years ago there were no vaccines, and the outbreaks would happen in Africa, and people would just die. And fortunately, the only reason one was developed was for the military, the U.S. military, and they collaborated with Canada and got one up to the point of a phase 2. And then when the big Western African outbreak occurred, they tested it.
Right.
And then apparently other companies, I don't know if they had already been developing them. There are obviously several now, which is always good, right, to have more than one.
Yeah, because money became available. So it's amazing what you can do when there's actually funding.
Very frustrating. Did I say, folks, that this pandemic of SARS-CoV-2 could have been prevented? I'm going to say it on every episode.
We may have mentioned that.
You should get furious about it. Could have been prevented. Someone posted a picture of a journal article published a few years ago, and it said in the discussion, the finding of SARS-like coronaviruses in bats that can infect human cells is a grave concern, and that's not enough to get any motion.
Yeah.
Well, now we are in the grave concern, folks. I know it's not your fault, but I blame the companies and the politicians.
Yeah, and I've lost track of how many papers I've read and meetings I've sat through and entire conferences I've gone to where people are talking about this with coronaviruses in particular, but also, there are other viral families that are pretty concerning. I mean, if I'd been betting on this, I actually would have put money on a flu pandemic before this, but that
you might get your wish.
Too.
Oh,
yeah,
know
exactly. That could still happen too.
You know what I saw on ProMed? Nipah. There's a Nipah case.
Oh my goodness.
Yeah, maybe we'll talk about that next time. All right, so we've segued into SARS-CoV-2 and COVID-19. Yes, 2 papers I wanted to just briefly talk about, which popped out this week. One of them in Nature, I guess they're both in Nature Medicine. Yep. Nature Medicine, Clinical and Immunological Assessment of Asymptomatic SARS-CoV-2 Infections. And this comes out of a variety of sites in China, like Chongqing Medical University.
I think are they all in Chongqing?
Looks like it.
I think they are. Yeah, it's various universities in Chongqing. There are 5 co-first authors.
Okay. All right, I'm not going to read them.
Yeah.
But this is...
Chunjin Long is the first author listed, and Ai Long Huang is the senior author, and apologies to the 4 other first authors. But
I think this is very interesting. So this is about asymptomatic infections, which we talked about last time, because as everyone remembers, WHO last week said that doesn't contribute much to spreading, and then there was a firestorm, and then they walked it back. Because it does. I went through a bunch of papers today with ample evidence that asymptomatically infected people can efficiently spread infection. And let's remind you what symptomatic means. A symptom is something that only you can feel. So if Dixon pricks his finger while he's tying a fly, only he can feel that.
It happens. It happens.
Does it happen?
It does.
Only
but the blood coming out of the finger prick is a sign.
That's a sign.
This is all true.
Everybody can see that.
Everyone can see that. So signs are what you can measure. So, in an asymptomatic infection, you may say, I don't feel anything. But as you'll see in this paper, if we take your blood, we can find virus and antibodies. And even if we look in your lungs, we can find things. Excuse me. I'm dying.
Oh, no. Are you symptomatic?
I periodically cough. I've been doing this for years. So the logistics of this study are very interesting. So this was carried out in an area of China where the Guangzhou CDC wanted to know how many asymptomatically infected people there were. This was back in February, which, as you know, was big time outbreaks in China, right?
Indeed.
So they were screening people by RT-PCR who were close contacts of confirmed infected patients, which is, of course, what we should be doing.
Yes.
But we don't. And they found 37 people who had no clinical symptoms in the preceding 2 weeks, but they were PCR positive, which is a sign of infection. So they're asymptomatic, but they had a sign because the nasopharyngeal wash said you have viral RNA in there.
No plaque assays, Vincent?
No plaque assays.
No plaque assays in this paper.
Sadly not. But
I just thought I'd ask the question.
Well, they actually say themselves we need to do infectivity assays because.
Although I was a little annoyed, they do say that on a couple of occasions that we need to look at infectivity and track how that's going on. But they repeatedly use the term viral shedding.
Yes.
To indicate positive. They say people were shedding viral RNA for this number of days after. Okay, that's not viral shedding. That's RNA shedding.
Right.
Yeah.
But minor nit.
Yep. So these asymptomatic patients, they estimate are about 20% of all the patients at that particular time. It's quite a bit, right?
Yeah, quite a bit.
Okay. Then they had some matched symptomatic and uninfected individuals, age, sex, comorbidity matched. And then they studied them. So they took blood and they measured, they just did clinical studies on the blood. And three of the asymptomatic patients had lymphopenia, reduced lymphocyte counts. One had thrombocytopenia, low platelets. 6 had elevated levels of a liver enzyme, and 11 had increased C-reactive protein, which is a sign of inflammation. And these people felt nothing. I often wonder, are there some people who just don't feel things that others do?
I'm sure. It varies. It varies from one individual to the next. What somebody considers. Yeah. I mean, and from culture to culture, what's considered appropriate for going to the doctor, what's considered appropriate for mentioning.
Yeah, that's right.
And some people are just very stoic about it. They'll say, "Oh no, I feel fine," and then they keel over, and
Right. There was no mention of whether you could smell or taste.
No, they mentioned. I think this is before that.
That was before. I think that was
okay.
And get this: 14 out of 21 asymptomatic had lung abnormalities on CT scan.
Wow.
I mean, not, obvious stuff, and these people didn't feel anything.
Smokers?
Did they look at smoking?
I don't remember. I don't remember seeing that.
Yeah, I don't think that was.
I mean, just living in Beijing will do that to your lungs.
Well, okay, but
but they're not in Beijing.
No,
they found them. They found them specifically in the RNA positive people rather than
right.
Yeah, not everyone. So our nucleic acid was found in. Well, of course, these were all PCR positive because that's how they were selected. They could find from 6 to 45 days in these asymptomatic people shedding of RNA, median 19 days. And then
That's a long time.
the other group, mild symptoms, the RNA was detected from 9 to 22 days, median 14 days. So this is a little counterintuitive. The asymptomatically infected people shed longer.
Yes.
As RNA, of course, it doesn't mean, that's why we need to know if it's an infectious virus. We could be being fooled here by this, right?
Mm-hmm.
They measured antibody, and get this, IgG levels were substantially higher in the symptomatic group. Is that right?
Yes.
Higher in the symptomatic group.
Symptomatic group had higher immune response generally.
Yeah, than those in the asymptomatic, which is weird because we said those were shedding RNA longer. So nevertheless, they have lower levels.
It kind of fit, I thought, because a lot of the symptoms that people feel are really symptoms generated by the inflammatory response, the immune response. And so it kind of, at least to me, made sense that the asymptomatic cases were not having a robust immune response, and that's maybe why they're asymptomatic.
Yeah.
Maybe why they're shedding longer.
So maybe
I think that's a big worry as to why they're getting reinfected.
I don't know about that, Dixon, but
there's some rumor on the internet right now.
Right. Yeah, we don't know if they're getting reinfected.
I don't know if they're getting. I mean, Daniel Griffin last night said, I shouldn't say last night because it's going to be here now. It's okay. Daniel Griffin said that it's not clear that they're, because I asked him that. Okay. So these individuals have lower antibody titers, and so maybe because of that they shed longer, but then as a consequence they're asymptomatic. I don't know. I don't know if being asymptomatic is like a person who normally has a lower antibody or immune response. In fact, beyond antibody responses, they looked at pro and anti-inflammatory cytokines, okay? And concentrations of these, 32 of them, were detected in and higher in the symptomatic group compared with the asymptomatic group. In fact, the asymptomatic group cytokine levels were the same as the control uninfected group. So they barely are making cytokines, which explains why they're asymptomatic, right? If they where they would be making it.
So it raises the question also about whether those people who are asymptomatic and shed for a longer time RNA, whether or not they are responsible for other people's illness. Are they shedding enough virus to infect somebody else?
For that, we need to look at infectious virus.
No, that's why I asked about the plaque assays.
Yeah.
Well, I mean, there are a number of modeling studies that have been done, which suggest, including Jeff Shaman, who suggests that a good fraction of transmission is coming from these undetected infections, both mildly and asymptomatic.
Yeah.
So,
in fact, that's from all that I've seen so far, that is probably why we're dealing with a pandemic right now.
Yeah, I mean,
yeah, this could have been prevented if we'd really been on top of it, but the reason SARS-CoV-2 is doing this, whereas SARS-CoV-1 didn't, was that for SARS-1, you weren't shedding virus until you were feeling crummy and had a fever and, were obviously sick. Right. Whereas for SARS-2, you're shedding virus and feeling fine and getting on your flight, and they take your temperature and everything's fine, and
Yeah.
Right.
So that's spread around the world.
But now, to really answer that after this is over, you do big serosurveys.
Yes.
And you ask people, did you have symptoms? And then you say, oh, look, 20% or whatever people are seropositive, but they never had symptoms. That's when you figure that out.
Yeah, and we need good serological tests done properly at a large scale in order to get to those answers.
Yeah.
Is that all we need, Alan?
Just that.
Because we don't have it now.
Right.
All right. The next paper is also Nature Medicine. It's coming from the London School of Hygiene and Tropical Medicine.
That's a good place.
I was going to ask Dixon, is it a good place?
It's a wonderful place. It even has its own bar.
So does Rockefeller.
That's true.
Did you ever go to that bar, by the way?
Many times. Oh, yes.
And this one has 2 co-second authors.
Davies, Klepak, Liu, Prem, Jeet, and the COVID-19 Working Group and EGO.
And I suspect that COVID-19 working group is a gazillion people. So,
and this one is age-dependent effects in the transmission and control of COVID-19 epidemics. I think this one is going to raise some eyebrows.
Yes, it certainly raised mine.
This is all about kids. how often are kids infected? They start with the sentence saying the COVID-19 pandemic has shown a markedly low proportion of cases among children. And they would like to know, is it because they have lower susceptibility or lower infection or lower development of clinical symptoms, so we're not picking them up? So this is actually it's a modeling study where they test their models by sticking in data initially from China and then from a bunch of other countries, six countries total. So they have an age stratified transmission model, which involves contact between people of different ages, not just among kids, right? And they fitted 3 variants of this model to the Wuhan data initially. So one model where susceptibility to infection varies by age, one model in which the clinical fraction varies by age, and one with no age-dependent variation in either susceptibility or the fraction of people infected. And all of the variants fitted the daily number of cases from Wuhan, but the model without age-varying susceptibility or fraction could not reproduce the observed age distribution of cases. And so then they said, well, you need to use other sources of data. So they went over to these other countries, Japan, Italy, Singapore, China, South Korea, and put those data in. And they come out concluding that people under 20 years were half as susceptible to infection as those aged over 20 years. Half as susceptible.
Which surprised me. I mean, it's a modeling study, so all the usual concerns with that, but a virus that kids are less good at spreading, it's counterintuitive to me. I mean,
well, they get less infected, but they can still spread it, right?
They can still spread it, and as they point out in the paper, kids have on average more social contacts during the day than adults.
Yeah,
and certainly schools being open would increase that. And from their models, they even extend this into the policy realm and what is the impact of school closing, and even going with their evidence that kids are, according to their model, less susceptible. You still get like 17%, 20%, something like that reduction in total spread by closing the schools, because even though the kids are less susceptible, they have more contacts, and so they do still spread the virus.
Yeah. They cite a previous study, where it says that school closures in SARS-1 did not have a substantial effect on those cases. But there again,
that's
very different, because most of the people transmitting were very sick.
Right.
So you wouldn't expect school closure.
They weren't going to school.
Exactly.
It also would depend on the country. And I was really amazed to see that they look at Milan, Birmingham, and Bulawayo, Zimbabwe. The median age in Milan, Italy is 43, Birmingham, UK, 30, and Zimbabwe, 15 years.
Really?
Amazing. Such a young population. Does that imply that a lot of people die when they get older? I suppose, right?
Well, that's probably the case.
So, their closing schools will have a different impact, and they modeled that as well.
I think the population that they picked from Singapore, by the way, was skewed, because hardly anybody who's a native of Singapore got infected. It was all guest workers.
That's true. That's true. So anyway, they say that, closing schools have a modest effect. So,
well, it protected the parents and the teachers.
Yeah, but it's not like every kid coming home is infected, right?
Right.
It's a fraction.
No, that's true, but
I don't know what's going to happen in the fall. I know some colleges are going to be open, but I don't know about.
I guarantee it'll vary from state to state.
Yes, for sure.
Or from school to school, because
maybe
Notre
from
Dame
district
is
to
going to
district.
open.
Yes, it may actually be 1,000 different outcomes.
Let me ask your opinion, gentlemen.
Please.
Should there be one policy for the entire U.S., you think, in terms of face masks, school openings, shutterings, and such? Should there be one U.S. policy?
Ideally,
I think we have one noise policy, don't we? It starts with the NIH and then CDC, and then after that, it's interpreted.
No, it's a state-by-state policy. Right?
It is.
No, but
they
don't have to follow the official federal policy, though. That's the one thing they don't have to do.
Yeah. So the question.
Should they?
I mean, there are a couple of levels to this. Virologically, do I think that there should be one U.S. policy? Absolutely. I mean, I think there ought to be just.
I agree.
The CDC says this is what we do, and in a pandemic, that's what we do, and that all 50 states do that. Legally and politically, do I think that federalism is an inherently bad idea, and we ought to the federal government have that authority all the time? Maybe not.
Well, just talking about virology, though.
But just talking about virology, I think maybe one of the things I'd like to see come out of this is, well, definitely one of the things I'd like to see come out of this is coherent law about pandemics and about what the government should and should not do during the next pandemic, because there will very likely be one, and have a clear setup. This is one of the things that happened in South Korea after SARS-1. They passed some laws that gave the government particular powers under emergency use in the event of a pandemic. And when SARS-2 came, they declared an emergency, said, okay, the government has the power to do things like, if you're infected with the pandemic agent, they immediately have access to your cell phone records, I think was one of the things, so that they can find out where you've been, which drastically simplifies contact tracing.
Not happening here, though, Alan, right?
I don't know. Is it? We enacted the Patriot Act after 9/11.
Can't get into the cell phone here.
We've got laws that essentially suspend the Bill of Rights when the government says so in the event of a terrorist attack. I think it would be far less drastic to have laws that say in the event of a pandemic, the CDC can have access to your cell phone records, and the policy set at the federal level for infection control would be enforced at the state level. So I don't know. I'm not a legal scholar, but I would like to see something along those lines come out of this.
So in School of Public Health, there are there used to be 27. I think they're now up to about 35 or so. Schools of Public Health listen to federal regulations and then espouse them to their student body. Okay, fluoridated water, meat inspection, food inspection, health regulations for restaurants, etc. All of those are set down in federal law. But once the state gets a hold of these things, they can reinterpret or choose not to respect those recommendations. Do you know of anything that's law that's not a recommendation from the federal government?
I believe food safety regulations, there are federal regulations.
Yes, there are.
Certainly when food's being transported across state lines. And that's one of the main ways that the federal government has authority to regulate states is interstate commerce.
Yes.
So that's in fact maybe a vehicle by which we could approach the pandemic legislation when there finally is some.
And water quality standards
where we would say,
also.
okay, if states want to depart from this, then they can't have any contact with other states. And they won't get any federal highway funding or what have you. So that could be kind of the stick. And so, there are regulations, and there are also, I believe, regulations where the federal government says this is the standard. States, if they want, can enact stricter standards.
Yes, but not.
They can't back down from
that.
These.
Is correct.
So you have to do at least this, and then if you're someplace that's super duper uptight, like the state I live in, then you can go up to this. If you're someplace a little more relaxed, you can do the bare minimum.
So what about vaccination then?
That's a whole other.
Yeah, no, but it feeds right into this question.
It does.
If there's a vaccine that works.
Right. Realistically, I think what we could get, and politics is the art of the possible, is measures that could be implemented in an emergency, in a pandemic. But I don't think we're going to get to a point where we can say there's a federal mandate for getting your measles vaccine. Yeah. As good as that would be for public health, I don't think that's going to be on the table. I think this is something where it'll be when there's an emergency, the federal government gets this additional power because it's necessary in order to contain the pandemic. And then when the pandemic's over, we go back to normal, and California and Texas can have different laws for things like routine vaccination.
Right. So many of the countries that have been involved in this particular pandemic are not exactly like our democracy. You take countries in Scandinavia.
Nobody
Japan.
building a democracy makes it exactly like ours.
No, they sure don't. South Korea, although they're being championed for doing the right thing, their governments work totally different than ours.
Yes.
So
yes.
That's really why there's so much difference in what we're seeing today.
It's
right?
one reason.
Yeah.
Yes. But there could still have been a well-coordinated federal response that would have served as an example to the states.
How about a believable federal response?
Yes.
That's the key. That
so primarily
the
the testing, which was bungled by CDC.
Yes.
Because they decided they wanted to do it all, and then they made a bad test, and blah, blah, blah. That was really the beginning of the failure.
Kind of set the tone. Yeah.
That's right. That's right.
All right, let's plow through some email here.
Sure. Hell of an idea.
Mark writes, it's just been hailing here, and now it's stopped. I don't think the temperature matters when it's sunny one moment and hailing the next. Mark brings our attention to a med-archive paper posted back in March, a Wuhan study finding that blood type O had decreased odds ratio, and type A increased.
I think we talked about this.
Did we?
Earlier, and this one, I don't know if this article has been updated, but when I read it back in March or early April, the data were not exactly blowing me away.
So now there's another study from Italy and Spain,
study, yes,
where 1,600 patients, type A blood, higher chance of severe respiratory failure than type O. So that's consistent with the original Wuhan study. Now, here's the thing. And what they do is they look at their genomes, and they find two regions of DNA which sequence variations were tied to how illness severity. And one region contains ABO blood type, but there's a close region nearby that controls immune responses. So I think they're too close to be able to dissect with this number of patients.
Exactly.
And so it may be that or the blood or both. Who knows? That's what.
If it was as simple as type A blood is the risk factor and that's the answer, we would have known that very, very early. That would have been obvious.
Well, the effect is not 100% anyway.
No.
People with type O are 9 to 18% less likely to get severe COVID. I mean, so that's just a little bit, right?
Right.
And the mechanism, if true, people are asking, what's the mechanism? I don't know. There are a lot of possibilities that have to do with glycosylation and so forth, but if you have to find out if it's really the blood group or the neighboring DNA.
Yeah.
Right.
Dixon, can you take the next one?
I can. Alexander writes, hey, just listening to your newest podcast and hearing the question about vaccines, hearing the question how vaccines will be delivered so that everybody in this world is able to get vaccination. Interestingly, yesterday, the European Union put forward an announcement that it will try to make sure that everybody has access to vaccination once available. So hopefully we can make sure that poorer countries also get access. I hope you will go on producing this interesting podcast. A lot to learn from there. Many greetings from Deutschland, Alexander.
Well, we've been doing it for 12 years? It's pretty likely we're going to continue, right?
Yes.
Well, I'm type A, so I don't know.
Are you type A? Yeah,
I am. I'm type A negative.
I'm O positive.
Oh,
I actually
lucky
don't
you.
know my blood type. I probably ought to
Is that
figure it out
true?
at some point. Yeah, it's true. I've donated blood, and I don't even know.
Well, someone knows what it is.
Yeah, somebody. I'm sure the Red Cross knows what it
That's
is.
right.
Whoever was
That's
running.
right.
So this is an interesting document from the EU. To help protect people everywhere, the EU is presenting a strategy to accelerate development, manufacturing, and deployment of vaccines, to everybody. We just talked about DRC, where a lot of people can't get the Ebola vaccine, right? So you have to, I'm not sure how you can deal with it, right?
If we can't vaccinate the world against polio with the live attenuated oral vaccine, I mean, there are going to be limits. I am
just so bad with smallpox.
Yeah, I mean, I'm hoping that The rich countries will at least spare enough capacity that the doses are made available, and we can try and get. And there are a lot of countries that are not in as bad shape as DRC that could benefit tremendously from very cheap, easily available, large quantities of an effective vaccine. But it's going to be those hard cases, the places that are really difficult to get into, that are going to be the last pockets. Or
you have people there that are going to keep you out.
That's part of the whole
that too.
Part of the whole picture. Yes.
Alan, can you take the next one?
Sure. Ken writes, I work on the practical side of health, and the education I got for that by nature only skips stones off of evolution and viruses on its way to hands-on work. I'm a registered massage therapist. Literal hands-on work.
All right.
Here in Canada, there's been a beep storm created by a politician for outing a doctor as being the catalyst for an outbreak of COVID-19 in a community that had none. While the doctor was in the wrong for breaking isolation rules, sadly, xenophobia is also rearing its hydra-like head and making the situation even uglier. So the doctor hires an investigator who says he can't be patient one in this case because various reasons, but I can see weaknesses in the investigator's argument too. In the end, it's going to cost the people of that province gobs of money for all the lawyers and financial payments to the doctor should he be found not to have been the spark of the outbreak, all because some politicians can't help but speak their minds before actually having a thought in them. My question is, would it be possible by getting the unique genetic sequences from all those in the infected cluster to know if the doctor was patient A, who passed the virus to B and then C and then D, etc., or is the genetic timeline not distinct enough to stand up in court? I don't know whether it is distinct enough to stand up in court, but I do know that it's possible to do these types of phylogenies, and that has in fact been done and taken to court for HIV.
For sure.
So there's precedent for this.
Yeah. Yeah, I found an article. There are many, but I found one where a gastroenterologist was convicted of attempted second-degree murder by injecting his former girlfriend with blood from an HIV-infected patient.
Good Lord.
Why would you do that?
Good Lord.
Well, why would you kill anyone, I guess?
Right, but that's...
And anyway, the phylogenetic analysis were admitted as evidence, and so I believe that you could do... I think you could do the same with SARS-CoV-2.
Sure.
Right.
And maybe HPV as well.
Oh, yeah, you could do it. You could probably do it with any virus if you really wanted these data.
Yeah, it's quite interesting. But unfortunate situation there. Yes, sorry about that. Daniel writes, thank you so much. I'm an alumnus from the University of Florida. I remember seeing Dr. Condit during someone's committee meeting, and I remember thinking he was quite intimidating. This podcast has shown me that he's really funny and an amazing scientist. I hope I can meet him in person someday, even though he's in Texas. My question is this: I want to have a career in science. I have no idea what I want to do. I would love to be a professor for the rest of my career, but not need to run a lab and write grants, just teach. I know adjuncts do that, but I don't want to be that for too long, just long enough to get a little experience. I would like to stay in Gainesville. Do you have any insight? If that is just a pipe dream, what would you recommend I do to get hired as faculty?
It's too bad Brianne's not here.
Yes, well, clearly there are positions where you can teach and not do research, for sure.
Yeah.
Yes.
I think you might find some in Florida. I think staying in Gainesville is a problem, frankly. In college, it's hard to restrict yourself. You know, scientists move around, and so I don't know how old you are, but you could certainly do that. But it seems to me that you should focus a little. You see, you don't know what you want to do, but you've graduated college, so you should find. So maybe you should go wash dishes in a lab and see if you like the research kind of end, and that you would want to teach that. That's what.
He's already got his PhD though, Vince.
He does.
Yeah, he's a mosquito biologist
from UF.
Oh, look at that! Yeah,
in microbiology and cell science.
So he's been through the ringer already. Basically, he knows
what I'd suggest is you say you don't know quite what you want to do, but teaching is definitely part of it. Take a step back and think about what it is you are interested in teaching, and if it's primarily teaching undergraduates, then as I say, that's something that can be done, and Brianne would be the one to provide insight into working at a primarily undergraduate institution, and she also does research, so these are not mutually exclusive. But the other thing to consider is, have you ever thought about teaching high school?
Right.
There's certainly a need for people who understand science to teach science at the high school level.
That's right.
I would imagine, well, obviously there are high schools in Gainesville. So if you're really stuck with the geography, look into that as a possibility. It's a very, very different teaching environment. The expectations are different. You may not like it at all, but you may love it. And one can make a career out of that and do good for science with that type of teaching. It's just an idea.
That's a good idea. I like that. Because
and there's junior colleges also throughout Florida.
Yes, there are also junior colleges. I mean, you've lots of those scattered around. Probably end up teaching anatomy and phys to pre-meds, and
that's right.
I mean, so if you start as an adjunct, can you transition to a professor? Right? Can you, a full-time professor? Is that a pathway? I don't know.
It depends on the institution. I think probably if you start as an adjunct at a community college, you can get hired on full-time at the community college. Mm-hmm. And a pure undergraduate school, maybe something similar. But I know at larger universities, the adjuncts are really just kind of a cheap labor pool, and they're considered disposable. So there may not be as good a path there. But that's something you could figure out as you get into the job.
Right. And the last resort, go back to your advisor that you got your PhD with and have a long conversation.
Yeah.
Dixon, can you take the next one?
I can. Scott writes,
Chris,
hey, folks.
Chris, no.
Chris?
Oh, you're right. Scott, you're right.
Scott.
Sorry. My apologies.
Short letter.
That's okay. You want me to read Chris? I'll do that.
No, Scott is good.
Scott writes, hey, folks. I was invited to an outdoor social distancing birthday party for my 70-year-old father, who is in cancer remission and has a weakened immune system. Any advice on whether non-essential gatherings like this are okay to attend or not? It will be outdoors, around 10 people or less, keeping distance. Not sure if everyone will be wearing masks, though. Thanks. Well, you're always taking a risk when you put more than 2 people together for this infection, that's for sure. But if these are all family members and everybody maybe they have an option for going and getting tested. And if they do, I would highly recommend everybody who wants to attend go get tested to make sure that at the moment they got tested, that they weren't harboring the virus.
That would be a good precaution to take, yes.
I think you have to wear masks.
Oh, and you have to wear masks. There's no question about that.
I think that'd be a really good idea. And it, the social distancing, stick to it. Because that's a big thing is people say, oh, we're social distancing. And then they're standing 3 feet apart next thing and talking to each other face to face.
That's right.
So I brought my car in for repair this week, right? And we're all wearing
again. Sorry, you can edit it out.
Don't talk me. You sound like my wife. Okay. Yes, again. I mean, I did it that soon. I thought I had forgotten. I have to get a different car. This one just it's got 240,000 miles. Everything is breaking. All right. Anyway, we're all wearing face masks. That's fine. And you go to the service manager's desk, and normally the chairs are right up to it, and they got the chairs back.
Exactly.
So they could be far away. It was funny.
Yeah.
It's fine. I think you have to wear masks.
I do.
It's essential.
Yeah, I would say that.
All right.
That's true. Except when you eat the cake.
Really, really enforce the distance.
Oh, this is what I wanted to say. So in the last TWiV that Rich and I did, we had a long letter about why social distancing is not an appropriate term. And I'll let you go back and read it, but it should be physical distancing.
Physical distancing, yes.
Yeah. Okay, Alan, please.
Wait a second.
Bless you.
You would have been none the wiser about that in the audio version of
Did you mute it?
I muted just in time.
What do you have? You clicked the button on the screen? That was quick.
Yeah. I felt it coming. I muted.
Most people can't find it because it's usually
I keep
off.
my cursor on it now. Because
you keep your cursor. Very good,
You're
Dixon.
damn right I do.
Thank you, Dick. Yes, the recordings have been very good lately, Dixon.
You're welcome. Thank you, Vincent. Thank you.
Chris writes, hello, professors. I'm writing to ask about the Global Virome Project. And my question is, can citizen science or non-virologists help? In particular, I know there are many hunters who bring in several million wild animals annually that could help reduce sampling costs for the project. Additionally, there are many scientists with animal samples in their freezers that they would be glad to part with. For example, I know several people in my department with marine mammal tissue, bird blood samples, and countless invert samples. Is there a way we could contribute some of our old or spare samples to the project? For example, my lab has several thousand bivalve, clam, oyster, scallop, etc. samples from the last decade, but I'm not sure if the Global Virome Project would want invert samples or how many they would want. I hope I can help. Well, Chris, when you're sending invert samples, just make sure you mark clearly which end of the box to keep up. Sorry.
Exactly.
Couldn't resist, right?
I think this is a great idea. I think the folks at the Global Virome Project should definitely contact veterinary schools. And in fact, Vincent and I met some folks at the Tufts Vet School when we went there who would be very interested in it. They were practically making us take test tubes with us when they were like, hey, do you know anybody who needs samples? Their wildlife clinic in particular has coded samples, like date and time coded samples of wildlife sampled across the Commonwealth of Massachusetts, geographically referenced. So if you would like a sampling of raccoons across an entire state, they can hook you up. They've got, all kinds of body fluid and blood type stuff. And I would say absolutely go with that. Hunters may be a little trickier, but if you contacted Fish and Wildlife Commissions, they frequently collaborate with researchers. I know they do stuff like with wildlife research, but they'll have a request for hunters as they bring in their game. Please let us know if you'd like to let us take a sample, type of thing. So that's definitely a source, and and you're right. Anybody who works on animals and has samples like this should
absolutely
let them know.
Yeah, I think this would be really interesting, not just for coronas, but other viruses too. And I sent this email to Peter Daszak, and he said, great, this is just what we want to do. I'll get in touch. So if others have samples, you could get in touch with him. His email
there's no reason that the Virome Project has to go out and do all this sampling themselves, and this could be very useful.
Mm-hmm.
This one is from Maureen. I appreciate that there are not great studies to back up the efficacy of general mask wearing by the public to reduce SARS-CoV-2 spread. However, I believe the anecdotal evidence is strong enough that I wish your team would more strongly urge listeners to wear masks rather than saying it can't hurt and it may help, as was stated in response to a letter on that show. I think some recent incident that occurred in Springfield, Missouri, just after our state started relaxing shelter-in-place orders, suggests that masks can be highly effective. In case you are not familiar with this story, 2 hairstylists reported to work at a Great Clips salon while symptomatic with COVID-19. Between them, they exposed 140 customers. More than 2 weeks later, none of them tested positive. Both were wearing masks, as were the customers. And it sends a link to the news story. Wear masks, folks.
Yep.
And it is scientifically accurate to say that we don't have the data on them, and I'm sure I'm guilty of this, because I always want people to kind of remember that this is not proven to protect. And one of the reasons I've emphasized that is because I am concerned, and I see this as I go out and do my grocery shopping. People put on the mask and they think that they are suddenly SARS-proof. And they forget about the social distance. Hey, I'm wearing a mask, right? I'm protected. Don't do that. Do wear the mask. Yes, absolutely. Wear a mask. Whatever kind you can get a hold of. I have a bandana actually that I just.
Dixon, are you looking at me?
I'm looking at you. I'm looking at.
Hey, actually, the sound goes through pretty well.
Yeah,
that's not bad, Vincent.
It does.
I wear one all the time when I go out.
Yeah. It's like putting a mute on your trombone.
Yeah, I mean, I don't wear it when I'm driving the car, but I wear it as soon as I get out of the car. I'm going to go into the store, or anytime I'm going to be around people. And yes, that's absolutely a good idea. It is probably doing some good. We keep accumulating more and more evidence that these are helping. It also, and I think this is probably really important, keeps you from touching your face.
Yes.
So you're not doing the types of things you weren't even aware you were doing before that would have helped get the virus into your mucous membranes. just remember when you're doing it, it's not some kind of magic armor. Don't forget about the physical distancing and the other measures, and do wash your hands when you get home. But yes, wear your mask. Absolutely.
And it shows that you have respect for everybody else.
It shows that you're paying attention. And
that's correct.
And don't walk around with it as a chin hammock. I see this.
Yes, I see that. Yes.
Or wear it so that it's only covering your mouth.
Yeah, that's
not
right.
Your nose.
Dixon, do you wear masks?
I do.
All right, good. I don't know why the hairstylists would go to work while they're symptomatic, though. You shouldn't do that.
Exactly. Because they need the money.
Yes.
Yeah, I understand that.
Yeah.
But that's one of the things now, next week, people are returning to work here now at the medical center.
That's right.
And we have big lists. I have to take a test, and there's an app I have to get, and I have to every day say I feel fine, blah, blah, blah on it before they'll let me in the building.
Wow.
It's a big deal. Maureen, by the way, drinks out of her TWiV coffee mug.
She does.
That's very good. Dixon.
Justin writes, Hi, TWiV. Hi, Team TWiV. I'm a PhD student finishing a dissertation in philosophy of science, where I study the transfer of mathematical models across disciplines. Whenever Rich says, quotes, all models are false, unquote, it makes me squirm in a way that I'm sure Vincent does when someone says killing a virus. I always respond in my head, but that's not a very precise way to use the word false. A classic problem in my area of expertise is, what is the relation between model and the world? And how do scientists exploit that relation to learn about the world? It seems that, by definition, models have to be unrealistic. Completely realistic representations of phenomena are useless for modeling. A classic analogy is how to use a one-on-one scale representation of England would be useless as a navigational map. So in one sense of false, where it means unrealistic, Rich is right. However, unlike with the sort of things we normally take to be false, assertions, propositions, sentences, a model's unrealisticness is a necessary condition for being useful for knowing something. By leaving out detail, a model is able to be especially useful, perhaps by highlighting the essential mechanism for producing some phenomena, or by showing only the relevant detail for navigating across England. Paradoxically, the more false a model is in the sense of realistic, the more true it is in some other sense, explanatory, salient, understandable. For this reason, us philosophers of science have mostly abandoned using the word true or false when theorizing about how models contribute to the growth of scientific knowledge. If you can all get Rich to change his word usage, I promise to correct my family whenever they tell me some disinfectant can kill viruses. Hope that was insightful rather than pedantic. Love your podcast. The best, Justin.
It's a good point.
It's a very good point.
Really,
yeah, it was absolutely.
So we should say models are inaccurate, right? Or
they are simplifications.
Simplifications.
Here.
Yeah, I agree that, false has acquired a bad connotation in these past few years, as you know.
Sure.
Yeah, so Rich, if you listen, if he doesn't, we'll remind him next week.
And somebody can wear false teeth, and they're not bad teeth.
Oh,
that's just what they're called, right?
Yes,
that's right.
All right, you're next, Alan.
Okay, Veronica writes, "Hello, Twivers. There have been some questions about the scalability and stability of mRNA-based vaccines for SARS-CoV-2. This manuscript, which is from a couple of years ago, offers helpful information about them. According to the article, mRNA production has a yield of about 2 grams per liter in multi-gram scale reactions. One of the major benefits of using bacterial expression systems to carry out production is that you don't have the issues with immunogenicity that production of biologics using a mammalian cell line can cause. But stability is a major problem. Which one of you commented on? Formulations to improve stability are appearing, but they are not great. Once encapsulated in a lipid nanoparticle, the stability improves, but the drug still doesn't have a great shelf life, 6 months according to the article, and requires low temperatures to maintain it.
Yep.
And Veronica is at the National Institute of Standards and Technology.
Nice.
Interesting.
So
leader in the biomedical microtechnologies group. So Veronica sounds like she knows what she's talking about on this score. Thank you.
So I don't worry too much about the shelf life because I think whatever they make, they're going to use.
Yes.
right away.
That's right.
Especially next year. But you do have to keep it frozen, which is the cold chain, and that's a problem.
It's going to be a challenge in a lot of places.
Yeah.
Mm.
So thank you.
That's not a challenge in wealthy nations where we already have vaccines and drugs that have to be kept refrigerated in transit. That's done routinely. Every pharmacy has equipment for that. But that's going to be a major issue in distributing it to the poor countries.
Also.
This is from Adam. Hello, TWiV. I am not a virologist or a physician, but just a neuroscientist. However, I have been listening to TWiV for quite some time because my virologist wife made me.
Oh, dear.
Good thing.
Yeah.
Your show is a true treasure and has even gotten me excited about viruses and not just the reagents for my neuroscience research. Your shows on COVID-19 have become essential listening for me. I especially like hearing from the front lines from Daniel Griffin. I was curious about something. At least in some patients, COVID-19 seems to promote strokes, perhaps through infection of endothelial cells. I'm wondering if this is an underappreciated aspect of all coronaviruses that use ACE2 as a mode of entry. Could such an association be pulled out of Jeff Shaman's data set? All right, so the strokes are probably... virus replicating in endothelial cells, I can't find any good evidence for it. We have another email later on about that. There isn't any good evidence. All the animal models, I've seen nothing. And there are a few papers. There's one paper that's widely cited. I think it's Lancet, where they studied 2 patients with vasculitis after COVID, right? And they do electron microscope and they see these particles in the endothelium, and they say, you see, the virus is replicating, but it doesn't mean anything.
No.
You can't even see if it's a coronavirus, frankly, and replication, who knows? So I don't think we know, and Daniel Griffin would agree that we don't know if it's replicating there. It seems to be a side effect of the cytokine aberrancy, and it doesn't happen with other coronaviruses. It certainly wasn't a fact. It's not a factor in the common cold.
The endothelial cells don't have ACE2 receptors?
They don't?
I don't know. I'm asked that as a question.
Let's look it up. ACE2 endothelial cell. You know, when you culture it, it can always be...
Well, you can overpower the system, right?
Well, ACE2 receptors are expressed by endothelial cells.
Uh-huh.
Yes. So they are.
What about the other receptor that I asked about last week or the week before that, whether there was another receptor for this virus, and they said no, but then neuropilin-1 turned up as a cofactor or a potential other receptor molecule. Because everybody on ACE2 inhibitors, they don't all avoid infection, right?
Yeah.
Right.
Yeah, here's a paper you talked about. Neuropilin facilitates cell entry.
Yeah.
This is a bioRxiv paper.
Yeah. So, in those patients, they would get less of an infection, but they'd still get infected.
Yeah.
I don't know.
Anyway, I don't see any evidence.
We're just speculating.
I'm sure there will be some more work on this endothelial cell issue. So stay tuned, Adam. Keep listening.
Indeed.
Dixon.
Anonymous writes, who? Dear Professor Racaniello and team, I've been listening to This Week in Virology since the episodes that were in the 580s. I do hope you will answer my question. My question is, if heat is so important in the transmission of droplets and aerosols, then how can you explain what's happening in Arizona right now? It's 108 degrees in Phoenix right now. That's pretty hot. Why is Arizona still seeing hundreds of deaths per day? Because they're all gathered at the pool. No, I don't live in Arizona. I live in New Jersey, where about 2 out of 5 panelists live.
3.
I love the podcast. Best regards, Anonymous. So
3 of us live in New Jersey.
Yeah. So
Me,
my son, my older son, was stationed at Luke Air Force Base in near Tempe, Arizona. And one day he said, they are not allowing the F-16s to fly today because if you rolled them out on the tarmac, Alan, you'll appreciate this, you must know this, the temperature of the tarmac was so hot it could deform their tires.
What do they need tires for?
Or 100. Well,
to roll down the runway.
This is not a carrier based operation here. So it can get extremely hot and it's extremely dry.
Well, Alan, you said that if it's too hot, the planes don't have lift, right?
That's another problem, yes. And depending on, there are actually some airports probably in Arizona, but definitely in like Colorado and Utah, where that becomes an issue later in the day.
Yeah.
It gets to be hot and it's high altitude, and
that's a strike two. That's right. Strike two.
Just getting the plane off the ground.
So this, so I have always felt that, so for a number of viruses, including influenza, we know that temperature and humidity are important factors in transmission. Many viruses are seasonal and increase in the winter. But I always thought that if you have zero population immunity, basically, that trumps environmental factors. So I found a paper that actually says that in Science, which is, they use a climate-dependent model to simulate SARS-CoV-2 pandemics on different conditions, and they basically conclude that during the pandemic stage of an emerging pathogen, the climate drives only modest changes to pandemic size. That's because emerging pathogens have distinct dynamics driven by high population susceptibility. Right. Yeah. So they say basically tropical and temperate regions should prepare for severe outbreaks in summer. Won't make a difference. It'll make a modest difference, if anything. But, after a flu season, you have a higher immunity in the population because the virus has been circulating all winter. And that together with the rising temperatures and humidity conspires to inhibit transmission. So it's probably not going to happen here.
And we've been seeing this. We've been seeing this with SARS-CoV-2 pretty much since the beginning. Yeah. We saw the Philippines had a major initial spike. That's not gone yet. And that is certainly not a chilly place.
Yeah.
No. And throughout the tropics, lots of warm places, and they at high humidity, at low humidity, it just really doesn't seem to make a difference. And I think Vincent's, this paper you linked to is exactly what's going on. It doesn't really matter that the virus has a harder time between hosts because it's going to find one immediately.
Alan, you're next.
All right. Dawson writes, "Hi, a few months back, you guys had a clinician, I think from Texas, who couldn't seem to understand pooled testing and dismissed it. Other countries have used it, and now it looks like they are finally getting imported into the U.S. and provides a link of the FDA allowing pooled tests. As far as I know, they date back to the 1940s, but I'm too lazy to track down the citation."
So this is an FDA statement facilitating sample pooling. So they said you can pool, but you have to validate the pooling.
Yes.
You have to show that it doesn't do anything bad, right? Like make it less sensitive or whatever. So it's not like you can just go and pool tomorrow. You have to do whatever it is the FDA requires. Right?
There are pool rules.
Pool rules. And you have to respect them.
That's right. Cool pool rules.
I mean, we didn't think it was a good idea because it seemed like you would have actually less sensitivity and perhaps interference, right? So if you had one sample that had an interfering in it, it would then interfere with everything else, right? That's one scenario. But if you can show that that doesn't happen, the FDA says, show us, prove it to us, and we'll let you do it.
Right.
Mm-hmm. I don't think we're talking about pooling hundreds of samples. I think, even if you could pool 5 or so, that would help maybe. Anyway, thank you, Dawson. Felix says, what do you think of this paper? So this is the Lancet paper that says the virus infects endothelial cells.
Right.
And I don't believe that the paper shows that. The authors seem to think they've shown that the virus infects endothelial cells, but there are no growth curves in the paper. And the particles, to me, I can't even tell if they're coronavirus. So I don't think that proves it. These are actually a clinical report of 2 patients, which, as I said, with vasculitis. And so, Felix, I don't know if it's possible. I asked Daniel. I said, is it a blood vessel disease? No, he said it's a lung disease, and there are other things that happen. So I don't think it's as simple as saying, the blood vessel infection explains everything, which is what a lot of people are trying to do. Please don't follow Daniel's example and get some sleep, okay? I get sleep. Well, I try anyway. Not always successful. Dixon, you're next.
Terry writes, good morning. Okay. We're all aware that people are more affected/infected with seasonal flu and the common cold during the fall and the winter months. My question is, where are these viruses hanging out during the spring and summer? I understand that they're not alive, but that under certain conditions will disintegrate. For example, let's say someone sits on a park bench during optimum conditions. His hands come in contact with the virus and he touches his face and contracts the virus. During the less active conditions, another person sits on the bench. The hands come in contact with the virus and he touches his face, mouth, nose. Will he not get the virus? Thanks for your explanation.
Well, even though influenza and other viruses are seasonal, between seasons, they're still around.
They're droplet borne, yes.
Yeah, they're droplet borne, but they're always around. They don't go to zero. There's someone infected, right? And you've heard of a summer cold, right?
Of course.
You get colds in the summer. People don't think twice, so the virus is always there at a low level. But for influenza, we believe it comes from the southern hemisphere in the next season, imported by travel or whatever. So the virus is never actually gone.
Would you catch this off a bench?
In theory, if someone was just there and put a lot of a bolus of mucus, and then you're there within a couple of hours and get that exact same place and touch
exactly,
maybe.
Exactly.
But I don't know of any documented spreading by contact. But whereas by people, most of the spread has been people being inside where they're breathing air of each other.
Yes,
so
in fact, there have been now a couple of studies looking at mass transit. Which is a perfect setup for this. I mean, everybody's holding the pole in the subway and then getting off, and they've got hands all over their faces, and the subways are in fact covered in human skin. If you do some microbe sampling, you get human skin microbiome.
It's a wonderful thought.
It turns out that that's not really spreading SARS-CoV-2.
No.
So that's they studies have looked at samples of cases and contact tracing, and I think there was one in South Korea and maybe one in Japan where they found that nobody had gotten it from the subway.
Right.
In an entire, it wasn't spread that way. It was all spreading in households and work settings where people were talking to each other closer together. So that the park bench scenario is probably not something I'd worry about.
But we should still wash our hands, right?
We should wash our hands.
Betcha.
For other reasons, but there's still some probability that you could.
Sure. And just because those studies didn't find it being spread on mass transit doesn't mean you should, pick your nose right after getting off the subway without washing your hands. Just wash your hands.
But
all New Yorkers do that. Don't you know that, Alan?
But again, the key here is that, and yesterday in my virology class, I showed epi curves of flu over the seasons, where you have a winter peak, and in the interpeak periods, there's some flu there. It's not zero.
Not zero.
Right.
Not zero. So that virus never goes away. On Wednesday, we had an email from someone in Hawaii who said, we have 0 cases. And I said, I bet if I went there, I'd find PCR positive people. If
somebody's got it.
Somebody's got it.
That's right.
Alan.
Let's see. So we're down to Stephanie?
Michael.
Or Michael.
Michael.
There we go. Dear TWiV, given the importance of dendritic cells to antigen presentation, the tissue localization of dendritic cells, and the normal route of exposure for many viruses through mucous membranes, wouldn't cutaneous, subcutaneous, or mucosal inoculation be better than intramuscular injection for eliciting an effective immune response for viruses like SARS-CoV-2 and influenza? On a related note, flu mist was suspended for a couple of years because of its failure to produce a large increase in antibody titers versus intramuscular injection, which used to be used in the standard flu vaccines. Could this lower antibody titer in serum samples be misleading? Perhaps there is a tissue-specific immune response that makes serum antibody titers high against muscular injection to protect against viremia, but relatively low against mucosal antigen challenge, which would elicit some sort of other strong immune response in mucosal tissues, which would not be as strong in serum antibody titers. Yeah, so the ACIP recommendation to drop flu mist was a little more nuanced than just antibody titers. They were looking at efficacy data.
Yeah.
And I think, Vincent, we were talking about this, wasn't it on a pre-COVID-19 flu.
Last year, probably. Yeah.
Yeah.
I think one of the
where
components
it turned out MedImmune had traced the problem to the virus that they'd used, the attenuated virus that they'd used for the H1N1 component.
Yeah. So I don't think that plays into this.
Yeah, I don't think it's now. MedImmune has argued that the attenuated vaccine may provide superior immunity, and that's entirely possible. And I think personally, I think FluMist is a great product because it avoids the needle, and it in the years when it's worked very well. But I don't think it's as straightforward as a dendritic cell type of thing.
The polio vaccine.
Yeah,
sorry.
Go ahead.
I was just going to quote Vincent on this because there were two kinds, right? When you inject and when you swallow. And if you take the injectable and then you catch polio virus, the immune system in your gut tract is still naive and you get infected, but you don't get sick. Right. Is that right?
That's right. Yeah.
So maybe he's talking about IgE or IgA antibodies.
No. What he wants to know is, look, this is a respiratory infection. Why would we inject a vaccine into the muscle? Exactly. I've always wondered that for flu, right?
Yeah.
Yes.
And it works because you make IgG and some IgA, and it goes into the mucosa, and that's clearly enough. Would it be better if you put the vaccine in the nose? Well, that's FluMist, right? And I'm not sure how much better it is. I mean, if I had a choice, I would take FluMist because it approximates a natural infection, but I'm not sure it's that much better than inject it. Right?
The efficacy data. So back before they had this problem with the H1N1 component, and it got taken off the list. There had actually been a recommendation based on some earlier data in previous years that showed FluMist was more effective, especially in pediatric populations, than the shot, which is great because kids really hate getting the shot. So, I was so happy, and I took my daughter to the pediatrician to get her flu shot, and she got it up the nose, and she was like, this is great. And I felt great about it because there's higher protection. Gosh, this is wonderful. And then, they had this problem. So yeah, I think this does make a lot of sense that we should vaccinate with a respiratory vaccine against a respiratory virus and get the real exposure to it. But it's hard to make those vaccines, as the experience of FluMist shows.
That has to be an infectious attenuated vaccine. And right now, people are just taking spike of SARS-CoV-2 and sticking it in different vectors, right? There's only one attenuated vaccine being made in China, and maybe that'll be put in the nose. I don't know. But the others, they just want to do it as quickly as possible.
Yeah.
And
the goal right now is to get a working vaccine as fast as possible.
Right.
And in fact, I personally, I think the most promising effort for that is the inactivated vaccine being developed in China, which is just the most obvious. We've got decades of experience with inactivated vaccines, and they grew up a quantity of it, and they inactivated it, and they're running that into trials. I think it's a great idea. But longer term, especially if we have to do booster shots for this, I think it would be wonderful to get an attenuated vaccine.
I also think the microneedle skin patches are very attractive because they put the virus in the skin, which is great because there are lots of antigen-presenting cells there, right?
That's right.
But again, those are just being tested for other vaccines, right? So if you want something fast, you're not going to do that initially, right?
Yeah. No.
That's my thought.
Yeah, so Michael, this is a very good point and an excellent idea that we should do this, but it's not going to be as fast.
Check back in 10 years.
Yes.
Well, frankly, I don't think we'll need a SARS-CoV-2 vaccine after 5 years, but we'll see.
You're right.
So I don't think there's going to be any vaccine development. Stephanie writes, a few episodes ago, you talked about some patients with COVID-19 confirmed positive PCR were then tested negative for IgG antibodies. How do these individuals clear the virus? Is the antibody test wrong, but Abbott's supposed to be 99.7% accurate? Are they using another part of the immune system? T cells? Asking because my husband and I were both very ill in March with classic COVID. He fought off the virus more quickly and produced antibodies confirmed with an Abbott test. I took about 7 weeks to clear, but tested negative. for antibodies. I think this is a very unknown area right now. So we measure neutralizing antibodies with a plaque assay, a plaque reduction assay, and you can't find them in a fraction of people, but maybe your test isn't all that sensitive, or maybe it's not measuring the right thing. Maybe the important antibodies are not ones that neutralize virus in a neutralization assay, but maybe effector functions that bind to FC receptors on immune cells and then recruit them to infected cells. Maybe it's T cells. We just don't know.
All these people, I'm sorry, Professor.
Obviously, they're clearing virus in some way, right?
Yeah, yes. I mean, interferon? Is that
it could be interferon, absolutely. Yeah. Who knows? Or a combination of the two.
We do not know the correlates of immunity for SARS-CoV-2, and we're not going to for quite a while, I think.
That's right.
I mean, the vaccine development efforts are looking at antibodies because it's easy to look at antibodies, and these sera surveys are looking at antibodies for the same reason.
Yeah.
And I think it's important to do those studies and use those measures in developing these things. But the real test is going to be, does exposure prevent reinfection, and does the vaccine prevent reinfection? And that's why you do the clinical trials. But yeah, I mean, if you had it and you were confirmed positive for the RNA and you had the symptoms, I'd say you cleared the virus, and I don't know how you did it.
Somehow. But I mean, people are worried about this, that you're going to get reinfected, but you're going to probably not have serious disease. There's something in you that responded.
There's something in you that has seen this virus and reacted to it and cleared it, and it'll probably do it again.
Exactly.
By the way, Alan, you would appreciate this. Every Monday morning, I do a 15-minute radio spot with some radio program, and the guy, at one point, he discovered Maurice Hilleman. Okay. He read an article. And he said, I never heard of this guy. He's amazing. Where's he now when we need him?
6 feet under, yeah.
Is that funny?
Yeah, that's good.
Interesting.
Dixon, I think you're next.
Yep.
Is that right? Yeah.
I am. Karen writes, hello. I understand that most, if not all, vaccines under development are using techniques that have never been used in vaccines in widespread use in humans previously. I find this fascinating and a wee bit worrisome. First, am I incorrect in my assessment of the vaccines? Virus vectors, mRNA, DNA, etc. Have they been developed and used previously? Second, if this is the case, that the vaccine form is novel for humans, should I be worried? Mm-hmm. I am so happy to find your podcast, even if 2/3 of every podcast soars over my head. That's okay, Karen. It does me too. So, sincerely, Karen.
Really, Dixon?
No, I'm not. Yeah, I was just trying to empathize with Karen.
No, I know. Sometimes we get in the weeds for sure.
Yeah, it's even more than
sometimes it's 3/4.
That's right. It's 4/5.
Karen, I wouldn't be worried. Some of these vectors have been used, as we said, for Ebola. VSV, modified vaccine, Ankara, Adenovirus. The mRNAs have been tested in many animal models. They're going to be extensively tested, so I wouldn't worry. What do you think, guys? Would you be worried?
I can think of lots of other things to worry about before I'd worry about that.
I'm much more worried about the virus than I am about the vaccine.
Here.
It is true that some of these platforms have not been into human trials before this. I think the Moderna thing had actually been through some safety trials in humans for other indications, hadn't it?
Yeah, they got to step up because they had used it before for something else.
Yeah, there was a
in Oxford too.
Yeah, and the Oxford vaccine they were already working on and had already gone into human trials for a malaria vaccine.
That's right.
The adenovirus vectored ones, that's been a long standing. I mean, there have been multiple trials on that. So these are platforms that have been kicking around for a while that have been tested in humans, at least to the toxicity stage. As Vincent said, there's the Ebola vaccines that are being deployed. Those have been given to thousands of people now. So in terms of safety, I'm not concerned about these really at all. My concern is about efficacy. And I am a little bit concerned that, especially in the U.S., where there's this really extreme political push to get the vaccine done as fast as possible, preferably before the November election. That's
right.
That we may end up in a position where we end up with a vaccine that's not as good as it could be, or, and then people get it and they say, hey, I'm immune from the virus, and then they go out and they get infected. That would be a huge disaster. Now, fortunately, there are people whose job it is to prevent that kind of thing from happening. I just hope they're allowed to do that job.
Right.
If it doesn't work, it's not going to be approved, right?
Right. I mean, you're going to have to show efficacy in the trial, and hopefully, that'll be good enough efficacy that it'll work out.
Yeah. I'm trying to see if any mRNA had been in humans at all.
Yeah, that one I'm not sure.
Not sure about that.
It was certainly Moderna's been working on this for a while.
Yeah, it's been in animal models for sure.
In animal models, and I don't really have safety concerns about RNA. It's just It's RNA.
No.
Oh, but that's phase 1 trials. I mean, her fears should be allayed by the fact that they're going to test for that.
Yes, somebody else will have gotten these shots before you.
Correct, and they actually got paid for it.
All right, who read that? Alan, right?
I did.
Oh, you didn't?
Oh, wait, no, Dixon read that.
Right? I read that.
Yes, Dixon read that.
So you're next.
Which gives me the right to get up, and I'll be right back.
All right, so Alan, you're next.
All right, Mark writes, hi, TWiV team. I especially enjoy learning about the immune system and how it works. My question is, for SARS-CoV-2 and in general, if the innate immune system effectively fights off an infection and doesn't need to pull in the active immune system in any substantial way, what would that mean? Would that mean that there wouldn't be any antibody production, or at least antibodies that are specific to a given infection? Not asking from the perspective of future immunity implications, but rather understanding seroprevalence testing. Right. So, sure. I mean, if your innate immune system takes it out before your adaptive immune system sees it, then you're not going to get a big antibody response. And somebody, probably Vincent, put in C paper above on asymptomatic infections, right?
Yeah. So, those people that were in that study we discussed earlier, right? Asymptomatic, yet they have antibodies for sure. They're not clearing infection. They're still shedding. So I don't know. There probably is another cohort of people where the virus comes in and it's gone in a day because of the innate system, right? So I guess in them, you wouldn't have an antibody response because that takes 2 weeks. And so those people would never score in a serological survey for sure. But I'm not sure what they mean anyway, because they probably epidemiologically, they probably don't mean anything because they probably don't transmit either, right? They
were probably dead. Your innate immune system, if it doesn't get the job done within a day, then or thereabouts, I mean, it's going to be, if you've got virus circulating in your blood, it's going to be seen by your adaptive immune system, and you're going to get some kind of a response, and presumably that would be detected at least a lot of the time by serosurveys.
All right, Charlie. Hello from the UK. I'm a GP working in Oxford. At the peak of the outbreak in the UK, I would estimate I was triaging 5 patients a day on average over the phone with COVID-19 symptoms. And as far as I'm aware, the vast majority never received confirmatory tests. As the weeks have gone on, this has dropped dramatically, which makes me wonder if the peak was many times higher than officially recorded, almost certain, but also if the decline in cases is steeper than officially recorded. As the outbreak has gone on, we have seen the phenomenon of persistent symptoms, including fatigue, myalgia, shortness of breath, chest pains, headaches, soft cognitive dysfunction, foggy but not overtly confused. Often still troublesome more than 6 weeks after first getting ill. My observation of who we send to hospital is that it's probably more based on frailty and comorbidity than on severity of the disease. I don't know. My impression here is that if you can't breathe, you go to the hospital, right? That's the main thing. The letter you read out about the difference between sensitivity, specificity, PPV, and NPV was interesting. I'd like to point out that PPV and NPV are not only dependent on timing, but on place. That's a fact we have to deal with in primary care constantly, is that the PPP, which is positive predictive value of any clinical symptom or sign or investigation, is considerably lower than for medics working in other settings. See someone in A&E with a headache, there's a fair chance it might be a brain hemorrhage. See someone in primary care with a headache, 99.9% chance it's benign. I'm sure it's the same for COVID. What's A&E?
Emergency room.
Yeah,
I think, right?
Admit and emergency. I think that's what it is.
That would be the ER in the U.S.
One
Somebody shows up in the ER and their chief complaint is a headache, and that they didn't come in from a car crash. Probably it's not just take a couple of aspirin. It's wow, that's a bad headache.
Yeah.
One of the things I always wondered was, why is it that people are so infectious in the pre-symptomatic stages? Is this because viral secretion is higher in the pre-symptomatic stages, or for some other reason? We have also started to reopen schools here based largely on research out of UCL that showed children were less susceptible to the illness and therefore less likely to spread it. What's your view on this? That's the paper we just did, right?
Yes.
That's right.
All right. So why are people shedding? Well, it really depends on the virus. This one sheds in this pre-symptomatic stage. And in SARS-1, you were shedding mostly at the peak of illness. That's when you transmitted it. Why? This virus establishes the upper tract infection, right? And in most of the mild cases, that's where it stays. They shed, and then the infection is cleared. It's just the property of the infection. I don't know if we know why.
And so to the question, why is it that people are so infectious in the pre-symptomatic stages? I don't know that they're necessarily more infectious in pre-symptomatic than they are in symptomatic stages, but they're certainly more likely to be out and about and exposing themselves. They're not exposing themselves, sorry, exposing other people to the virus that they're carrying.
Yeah. But of course, if you're infected in the nasopharyngeal cavity, it's a great way to shed and spread, right? Because the virus is right there, and as you breathe, it comes out. Whereas virus down in your lung, you really need to cough pretty hard to get that out, right?
That's right.
Less likely to transmit. But you know this. You're a doctor.
Yep.
Exactly.
Dixon, you're next.
Mark?
Oh, no, wait, sorry. He asked, what do we think of reopening schools based on this?
Oh, yeah, school reopening.
I don't know. Do you love your kids? Send them to school. No, they're not going to get very sick. I think that the paper
But
basically...
are you going to get very sick when they come home?
Yeah, the paper in the end said, this can inform us, but we need to make... More information needs to be put into the decision, which is, okay, here in New York City, or are you in Bozeman? Where I spoke with David Quammen the other day, he said we have no cases, right? You could probably open schools. Maybe you could test everyone in Bozeman. There are not that many people, and see. Yeah,
but Bozeman attracts students from all over the country, though. That's just not Bozeman. Sorry.
I don't know. I don't know what the solution is. Frankly, I'm now leaning towards opening life because we can't shut down for another year. It just ain't going to work.
Even Tony Fauci says that, too.
And I think we need to test and face mask and keep away from each other.
Testing, tracing, and isolation.
Tetris.
Yes. That's right.
If we can actually get the testing and tracing going, then I think we could reopen a lot of stuff. And again,
Absolutely.
Masks are not magic. Social distance is not magic. But testing and tracing, that could really, that way when you do get a spread event, you know it, and you can isolate those people and stop it before it gets out of control.
So I think here at Columbia, I've been telling people, if you want to have kids in class, everybody needs a PCR test every week.
Correct.
All right. And then you quarantine and track contacts. You have to space people out. Look what they're doing for the college football teams are now going back. They're testing them all, and they're finding, 7 out of 20 of these guys are positive.
That's right.
Go to the hotel for the next 2 weeks, right? That's what you have to do. I do think. Okay. Dixon, go ahead.
Mark writes, "Hi, TWiV. I started listening to you guys a few months back when my wife suggested I take a listen. She is currently an immunology fellow and has been listening for quite a while. I'm an electrician, and it's become clear I may have missed a calling in my life."
Hey, listen, this wife thing is getting to be
I know.
Recommended by your wife.
I know. This is a big disparity in educational backgrounds, so this is quite interesting. Whenever there's an episode with a ton of relatively easy information, I share it throughout my social circle to do my best to offset the spread of COVIDiots. But being that I am a tradesman and former grunt in the Army, my circle tends to be a little less scientific and a little more conspiracy, make America great America.
again.
Yeah, make America great again, as I should have said. I really don't know how you are all able to keep your cool demeanor when explaining off some of the conspiracy talk that comes up. It amazes me. My blood boils when I see that crap spreading like wildfire. So kudos. Yep.
Well, Mark, it's great that you're trying to understand it. I really admire that. And
you have an interpreter built into your system.
Yeah, you can always ask your wife, what does this mean? But I think this is what we would like, more people in the trade who may not necessarily have a scientific background trying to understand what's going on. And the conspiracy talk is crap. You said it. It's great. That's just great.
And it's great to have people out there who are, in contact with the folks who are spreading that information.
That's right.
And as an electrician, you can talk to other electricians or plumbers or people you see on the job and be, oh, well, wait a second. It's not just those eggheads in the ivory tower. This electrician I was working with also said that was a load of BS. Yeah. Maybe there's something to that, so that you have a level of credibility that we don't.
That's right.
With depending on the audience. So that's great. And welcome aboard as a listener.
It's interesting that we tend to demote or at least underrate the curiosity index of people without a formal education beyond, let's say, high school or undergraduate college. I did a lot of work during my summers between my freshman and senior year in college, working in a carpentry shop, making kitchen cabinets, and then working on delivering them and installing them and things like this. And you would be amazed how informed and how curious most of them were World War II vets and Korea vets, and they were an amazing group to actually be around. I learned a lot from them.
I worked in construction during the summers in college, and there were some people who grunt laborers who didn't really have a trade because they weren't up to it. But I think just about everybody I met who was trained in some field of it and had made, like the carpenters, the electricians, the plumbers, they're smart folks.
That's true.
They've got, and they're, and I wouldn't even say that they didn't have the level of formal education, because there's a whole process. I mean, you don't just show up and say you're an electrician.
That's right.
There's
it
like
depends
this
on the
whole
state.
apprenticeship thing going on. And wiring a house, that's a complicated job.
He's a simplified neurologist.
Yes, exactly. He's a practicing high voltage.
That's a practical neurologist. That's right.
I don't think curiosity has anything to do with what kind of job you're doing.
Curiosity is the human birthright.
I think some people have really rough lives. They don't make enough money. They have multiple jobs. They don't have any time to be curious, right? And I feel badly, because the world is a really amazing place. And if you get curious about something, you find out stuff that's just amazing. And, as scientists, we're really privileged to be able to study this stuff.
No, we are. That's the question.
I have run into people everywhere who are curious. And unfortunately, then where do they get their information? That's the problem, is they find wrong places and then they get misled.
That's right.
Alan, you're next.
John writes, "Hello, Twivians. I would like to suggest recovering the news of the CDC mixing coronavirus PCR and antibody tests at an earlier time stamp in a future podcast, perhaps after Daniel's clinical updates. This way, listeners who may not stay till the end will get to hear how an agency that is supposed to protect everyone, poor and rich, regardless of political party, is being run in such a way as to mislead and endanger the health of its citizens." Now, for an analogy, would you mix water with motor oil and then use it in your engine? No. Then why are two separate tests being treated as the same thing? Verified evidence and understanding the truth are more important now than ever. Literally, thousands may or may not die from decisions made now, and evidence is the best available tool we have with which to make those decisions. I live in Australia and cannot be prouder of how my countrymen have banded together to stop the spread of coronavirus despite political differences and personal costs. The extent of the outbreak has been much smaller than in the U.S., and our country is beginning to open up with the sense that secondary outbreaks can be controlled. A semblance of normal life is getting closer. I'm also a U.S. citizen and have been appalled at the misinformation and willingness to let people die unnecessarily for the sake of political and economic gain. Ask the question, what does this person have to gain if I believe what they say? And also says, be kind to Dixon. John is in Melbourne.
Thank you for that.
He also said something here. Social distancing in Tetris work.
Yeah.
Physical in Tetris. That's a thing that got started by Kathy here on TWiV. It's great. Yeah, so you should read the rest of this letter because it's got a lot of interesting.
I did excerpts.
And is there some foul language as well?
We now have 145 pages of.
We have very passionate people here.
We do.
Jake, I found this short report from the JAMA network. In it, the authors report they detected SARS-CoV-2 in 6 of 38 patient semen samples collected during a cohort study in Shaanxi, China. However, they only report performing qPCR. We know from TWiV, yes, that positive PCR does not indicate the presence of a virus. Am I missing something here?
No, they are.
No, you've got it. I think it's great. We don't know if there's infectious virus there.
Right.
And I've looked it up since, and we still don't know. There's no report of infectious virus or of sexually transmitted infections, as far as I know. Now, with Zika, of course, they found first PCR material in semen, then they found infectious virus, and then they found sexual transmission. So that's the timeline, and it's not been done here.
Well, I would point out, though, with Zika virus, that's a vector-borne disease.
True.
Yeah, it's unusual, right?
It was a little surprising that people were contracting Zika virus without obvious exposure to the vector that was infected. In this case, it's going to be very difficult to sort out whether sexual transmission is happening.
Yeah, I understand.
Because, I mean, that's close contact.
Yeah,
so did you?
Yeah,
what was the root? It's not going to.
It's not the only bodily fluid you exchange with your partner.
I don't think you can separate.
Yeah, so for Zika,
you were obviously not social distancing.
So for Zika, it's very, very rare. But there was one case where there were no mosquitoes around, for example, and so forth. So anyway, so in those cases, we say it's sexually transmissible.
Yes,
sexual transmission is like the main route.
That's right.
While I'm aware that there's confusion regarding what positive PCR means, i.e. presence of genetic material versus replication-competent virus, do you think WHO and other public health authorities need to clarify this when issuing guidelines? Yes, I think they do.
Yes.
I see more and more now people saying PCR does not mean infectious virus. And I'm very happy because 5 years ago, they never said that. They never said it. They say, oh, yeah, it's PCR positive. It must be virus there. But I don't know what it is. But, certainly here on TWiV, we've been hammering away on this for a long time. And I'm sure it's not us. But I'm glad there's an overall increased awareness of this.
Yeah. I saw an article a little while ago about people who had been quarantined in China during the initial outbreak. And they got their testing, tracing, and isolation going on, and they were quarantining people. And their rule was that you had to test negative a certain number of times, like 2 or 3 times in a row, in order to be released from quarantine. And they were doing PCR tests. And so there were people who had been in quarantine for months.
Yeah.
Because they were still shedding RNA. And I was thinking, they really need to check for infectious virus and let these people go if they're not shedding infectious virus, because they're and as we saw in the paper, one of the papers we talked about today, you've got people out 30, 45 days after infection, you can still detect the RNA. It's just because that's there doesn't mean that they're infectious, and we really need to we need to get that across. So it's good that they're starting to pay attention to that.
So on Wednesday, Rich and I did a preprint from the Netherlands where they looked at mildly and more seriously infected patients. They did PCR and recovery of infectious virus and serology.
Oh, good idea.
And they found that, below a certain cycle number of the PCR, if there's a lot of RNA there, then you're likely to have infectious virus. And if you have more antibody, you're less likely to have infectious virus. So they're suggesting, and they need to do more work on this, you could combine PCR and serology to say there's not likely any infectious virus here. Because you can't do infectivity assays on everyone.
Right.
Obviously.
That would be That would be great if you could do that, if you could triangulate with something like that, because the infectivity assay requires a much more sophisticated lab.
Yep. Here.
Dixon, you're next.
Valerie writes, recently discovered your podcasts, and I'm loving them. Your latest podcast on bats and coronaviruses was of special interest to me, as it vindicated my refusal to explore a cave in Guinea, which was densely inhabited by bats. This was 9 years ago, and I still remember vividly entering this cave that was so full of guano that I promptly said, I don't think this is a good idea. I'll wait for you outside. Too much bat shit in here. Valerie.
That's great. Yeah, I don't think it's probably a good idea to go into caves that are full of bats in general, right?
Yeah,
I would agree.
Unless you have BSL-3 garb on. Alan.
Catherine writes, good evening. I just wanted to say thank you for answering my questions. It's hard to find sources that will tell you the truth these days. The media is sugarcoating everything so much it's a miracle our phones aren't in a diabetes pandemic. That Memorial Day pool party in Lake of the Ozarks you were talking about wasn't in Arkansas. It was in Missouri, about 50 miles from me. There were several venues on the lake that had pool parties that weekend. The largest one had all the photos in national media and was called Backwater Jacks. I kid you not, the name of the pool party was Zero Ducks Given. I've attached a picture of their advertisement for the party along with a notice that my county's health department informed them an attendee of the party did test positive for SARS-CoV-2.
Oops.
I guess maybe they'll give a duck now.
Oops.
All right, let's do one.
The geographic
Let's do one more round.
Okay.
Corvin, thanks for your excellent work. Daniel, in his, as usual, excellent clinical update and Q&A, briefly discussed the question about vitamin D and said even if it boosts immunity, boosting immunity might turn out to be problematic in the post-viral stage of severe illness. I do not make claims here, but would appeal to Brianne and ask whether this global picture of an immune response either being boosted or not might be misleading. I wonder if immunomodulation might not be a more general and appropriate term than boosting, and whether other immunomodulators that are widely used, cannabinoids, benzodiazepines, etc., might not have either welcome or deleterious effects. With respect to Sweden responses, as this discussion appears bound to continue, can I make a plea for only reading contributions to the debate that cite evidence and omitting those that boldly say so-and-so made a lot of false claims without supporting justification?
Did we already read this letter?
I don't think so.
This sounds
familiar.
It sounds really familiar. Maybe somebody else asked something similar, because I remember Brianne talking about this notion that no, you don't generically boost or inhibit the immune response.
I think she did say that.
Maybe there's with a lot of stuff going on.
Could have been another question. But, now there's, what's the immunosuppressant that's hot now?
Oh, the dexamethasone.
Dexamethasone. So
the steroid, yeah.
And Daniel said you don't want to give it early. You want to give it late.
No,
when you're having these immune problems, because if you do it early, it's a problem. Yeah.
So and in fact, the clinical trial was patients who were on the ventilator, right?
Yes. Very serious.
So that's not early.
No, it's not early.
They had a significant improvement. Don't show up with a cough and expect your doctor to put you on steroids.
Exactly.
But, the vitamin D is another one of these associations, right? Which requires some clinical trial to sort it out. And right now there seems to be an association, right, between vitamin D.
The difference I would point out with vitamin D is there's not really any downside to taking it.
No, you don't want to take too much, though, right?
No. Don't go out and chug a bottle of it. But if somebody feels like picking up a bottle of vitamin D caplets or something and taking it, it's fine. Just take the recommended dose. It's not going to hurt you. And it may turn out that helps.
Yes. And so, they are doing controlled trials to see if minimum daily requirements or whatever. We'll see. But yeah, if you want to take vitamin D, it's not hurting. I'm not.
No.
Dixon.
Wayne writes, hi, Twivers. I live in Wakayama, Japan, with a population of 900,000. Here, all restaurants limit the number of customers and have seating and tables at a distance. City Hall, every other seat is booked. I'm sorry, I'll read that again. City Hall, every other seat is blocked. Folks bow, no handshaking, and the culture emphasizes keeping distant. The emergency announced by the Prime Minister Abe was met with thankfulness, and as a result, our numbers are very low nationwide. Wakayama, 63 infected, 3 deaths, population as stated 900,000. Your podcast is beyond wonderful and is a cool spring of wisdom in a desert of confusion and misinformation. That sounds like a haiku in the making. I've got to.
Yeah, it does.
I don't know how, but I'm going to work that up into a. By the way, Japan's population is 126 million.
They've done a really
Best
good
wishes.
job.
And that's a fantastic. And of course, there's a number of islands, and there's all geographic separation.
And they've done a lot of face masking too. So
They have. They actually have. Well, they do it anyway. You know, people walk around with those masks all the time.
It was already popular there.
That's correct.
But the real story, as with the other nations that got a handle on this, is that they took it seriously and they shut things down when they needed to, and they got the testing up and running, and they did tracing and isolation. They did all the right stuff. It's not masks in isolation are not.
No, totally agree.
But sure, that too.
Okay, Alan, last one.
Raleigh writes, I was just listening to TWiV 617 and felt my heart sink when the letters about Sweden were being read out. I'm not going to try to second guess the politics or motivation of these contributors, but it suddenly sounded very similar to the debate around climate change. I'm sorry to say your science of virology is about to change forever. It has made the heinous mistake of supporting policy that impinges on those with a libertarian bent. They do not take to this kindly, and I can absolutely guarantee that huge sums are being spent by extreme political lobby groups and think tanks to ensure the general public are confused about the science of virology, and even worse, confused about scientists' motivations for trying to communicate it.
Do you think that's true, Alan? The science of virology is going to change forever?
I don't think it's been changed forever, but I do understand kind of what Rowley is saying, that the folks of certain political persuasions are very resistant to data of certain types, especially if it threatens their preferred worldview.
Yeah, I mean, I can sense that in the kinds of letters we're getting, which are very different from the kind of science-based questions we usually get. And I welcome a return to pure science, I guess.
Yeah, the letters we're reading today, there's a prioritization going on here, and in fact, we've had a discussion about certain categories of letters that we're receiving now that we've got this whole audience coming in, and there's stuff we're just not going to get to, but we're going to cover the science letters as we are doing.
Yeah, I try and pick the ones that have good scientific questions and are interesting and different.
But at the same time, I hasten to add, if you send in a letter and you're saying, "Oh my gosh, I thought I had a good scientific question," you probably did.
No,
we've got 145 pages of these, so
everyone has really good questions for the most part.
Yeah, a lot of people have good questions.
I have to say, if the subject line says I want to complain about something, I may not read it, because ask questions, don't complain, right? This is TWiV. It's number 629, microbe.tv/TWiV. You can find all the text of the emails, show notes, which are links to the articles and so forth. If you want to send us a question or comment, TWiV@microbe.tv. You don't have to have a question. You could send a comment and have a good point or something. That's fine. And if you like what we do, consider supporting us. You can go over to microbe.tv/contribute, and there are ways where you could give us a small amount of money a month, or a piece of money all at once, whatever you want to do. And we would appreciate your support. We do this for free, and because we love to educate. Dixon Despommier is at trichinella.org. And I'm going to put out one of your other websites today. Despommier.photoart.com.
Wow.
All one word. Very nice site, Dixon. Thank you very much.
Thank you. This is great.
Alan Dove is at turbidplaque.com. He is Alan Dove on Twitter. Thank you, Alan.
Thank you. It's always a pleasure.
And I'm Vincent Draccaniello. You can find me at virology.blog. I want to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Draccaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral. Dixon, show him your fly.
Hey, keep it clean.
No,
oh, nice.
These are little stonefly imitations, Alan.
Ooh, very cool.
Where do you get the raw materials for that?
Various hunters.
he gets his hackles up.